this was a really tough decision. And when they make it personal, that's when because we've left 90% of our content is controversial.
Yeah, we get
and
a lot of like sexualized
to be.
death threats.
But then when that stuff comes in and if they bring my kids in or anything like that, like shutting that right down.
It's frequently said that doctors aren't scientists and we need to stop speaking as if we were scientists. Well, my next two guests are both scientists. Please welcome Dr. Steyer and Dr. Love to the show, hosts of the Unbiased Science podcast, to debate that very point. And when I say debate, it's more like discuss, because we not only discuss that, my RSV controversy, all the topics that exist in the health and wellness space surrounding natural supplements, natural cures, and is inflammation to blame for all of our problems? This is going to be a really contentious, exciting, educational, and even collaborative conversation. So please enjoy. Let's get started with the checkup. I have two scientists in front of me. I am not a scientist, but I feel like doctors like to think of themselves as scientists. It feels like you have a controversial stance on this, at least within our community of doctors.
Correct.
Who wants to take first stab at proving why I'm not a scientist?
Well, I think the thing is that some clinicians are scientists, but not all clinicians are scientists. And the public just automatically assumes that all clinicians are scientists. But I mean, you could speak to this better than we can. My husband's an ER doc, and he always says he had no formal training in epidemiology and data science and how to critically appraise evidence. You don't get training in that. So yes, you have clinical expertise, but do you all know, do you? I mean, I don't know. Do you know how to really read and critically appraise research?
I would like to take a step back.
Okay, sorry.
No. This is a good place to be. But for the audience, what is your definition of what a scientist is versus a clinician?
Okay, that's a very good question.
So I can jump in. I think there is a difference. So I think clinicians can often be called like applied scientists, right? So you're taking scientific information, things that have been designed, developed, evaluated by trained scientists, basic scientists, you could call them, and are using it to apply to treatment of a single individual. Whereas scientists, by and large, are looking at population level information. Right. They're designing studies in order to evaluate or investigate a given phenomenon or an observation. And then they're evaluating the data that they collect to make generalizations or interpretations of the body at large. And that could be an entire human population. It could be a population of cells in a petri dish. It could be a population of animals. But it's very different because you're making these broad conclusions based on a comprehensive body of evidence, as opposed to tailoring the knowledge that's been created by scientists in order to apply it to a single individual, if that makes sense.
Makes a lot of sense. Now, why is it on a practical level an issue when a doctor starts treating themselves as a scientist when they don't have the background knowledge to do so?
Well, I think the biggest thing comes down to the training in study design and interpretation of the data. So a lot of times clinicians are going to be provided clinical recommendations, right, from a variety of credentialed organizations that provide clinical guidance, right? Like you're not expected to pull out treatment plans, out of a hat, as it were, right? There are a lot of standard procedures, not to say that there aren't exceptions, right? Certain cases, and that's why, you collaborate and have differential diagnoses and try and, investigate the problem. But there's not a lot of formal training with regard to, okay, is this study designed in a way that will appropriately evaluate the question at hand? Are we actually collecting the data that need to be collected? Are there variables that may skew these data that we're not accounting for? And, that's totally fine because people can't be trained in everything, right? There are reasons that there are specific fields of expertise, and that's why scientists and clinicians really need to work together to do that. Yes. Because just like clinicians, we're not going to go treat people. Right. We're not going to go make treatment recommendations. We're going to say, okay, well, the data support this as a treatment for X, Y, and Z, or the data do not support, the evidence for the treatment of X, Y, or Z.
The way that I'll put this on a practical perspective is if I have a patient in front of me and I am a clinician, I'm a doctor, I am going to diagnose the patient based on my evaluation of what's going on, which includes a history, a physical, potentially some tests. And then my treatment plan will come from the evidence that was collected by scientists, that was evaluated by scientists, and therefore these clinical guidelines that were sort of laid out for me, I go off of those.
Yeah.
Right.
And I feel like good quality clinicians, which is myself, would go, not saying that I'm a good quality physician, but meaning the clinician is myself, will base their decisions more so off good evidence-based data,
Right.
as opposed to just solely their experience.
Exactly.
Yes.
Right. And we just want to say, like, we are pro-clinician. Like, I think a lot of times we're pitted against clinicians, and
Right.
that's why I'm so happy that we're tackling this. Because it's like people assume that there's a hierarchy and that clinicians are at the top and we're just somewhere in the middle.
Yeah.
Right.
But that's not the case. You guys are amazing. You're experts in treatment and, diagnosis and treatment and all that. But you're not necessarily trained in the scientific process. And so, like Andrea was saying, people can put anything they want. Like, you could publish anything, but we've been trained to understand the quality of the evidence. And that's like the eye. That's how we approach all the information that we consume is, okay, what are the threats to the validity and the reliability of this? Is this generalizable, or is this just an anecdote? Is this an outlier? What's the body of evidence? What's the scientific consensus?
Of course.
And that's where I think the difference lies.
But I do want to also make the point, and I know, Ethan and I even spoke about this. So Ethan's
That's my
her husband. Yep.
Shout out to
ER
Ethan.
doctor.
Yes.
Dr. Ethan Chapin. So, he has come up against this as a younger clinician, where some of the older, more entrenched clinicians are very, intractable in this expertise-based or experience-based practice, as opposed to an evidence-based practice. And younger clinicians, more, newer generations of clinicians are really looking more to the science, which is great to see, because that's how it should be working together, right? But we saw a lot of this during COVID and during a lot of other medical issues. But a lot of people, you can publish an opinion piece in prestigious journals, and the general public doesn't know how to discern, this is an opinion piece with no data to support it, and it happens to be in a journal name I recognize, versus a very well-designed study with an appropriate number of sample subjects, appropriate number of controls, whatever the case happens to be. And they're really unable to discern, like, well, why is this one credible and this one isn't, when they're in the same journal?
Absolutely. I don't think it's one or the other, because when I get general guidelines, population-based guidelines on what I should do for a given patient, I have to remember that is not given to that patient.
Yes.
Because if that was the case, AI would just diagnose and treat everybody.
Right.
But the reality is, medicine is the science and art. That's what I think differentiates a clinician. They have to incorporate that art.
Yes.
Where in the lab, if you're doing art stuff, maybe that's a problem, actually. So I think the human is part of the art form.
Yeah.
So while I may know, I'll just finish the point. I may know that this is what's recommended for patient A,
Right.
but I know patient A has a bias, or they've experienced something with this negatively, and I know they won't buy into this yet, and I have to take an extra visit for this. I can adapt the research that you've provided me into an individual.
Exactly.
piece of
And I
advice.
think that really comes to the crux of all, like, science and health in general, is that it's multifactorial.
Yep.
Yes.
And too often people get hung up on this, like, singular anecdote and not realizing that there's a lot of other factors in play, and what works for a single individual does not necessarily mean that is, the de facto data-driven evidence.
And I've seen a lot of clinicians get frustrated with scientists and these guidelines, because it's like, I'm the clinician, I'm sitting in front of the patient, I know their history, like the nuance of their clinical background or whatever. Like, why should I follow a guideline? I'm the clinician. And so working in data science, like you mentioned, AI and machine learning, and there's all these amazing things that I think are going to come out in the next few years, where we could figure out, okay, this patient has a probability of success or of being discharged if we follow XYZ protocol. But we always have to work in conjunction with the clinician. I don't think personally, and I know, Andrea, I don't speak for you, but I think you agree, that should never supersede your clinical judgment, but we're a team.
Yeah.
And I think, like, that thinking needs to change. Like, we're often pitted against clinicians, but we are a team.
No, the
Yes.
team aspect is absolutely right. The multifactorial thing is right, because multifactorial is probably the answer for all of these things that we're going to be discussing today.
Right?
Nuance, as Jonathan Haidt said actually on my channel, is a superpower that we need to
and is lacking in
most people.
Yes.
I will say, to play a little devil's advocate, older clinicians will oftentimes rely too heavily on anecdote and their experience, and therefore less so on evidence-based medicine. I have seen that pattern. At the same time, I have seen a new pattern in my younger residents that I'm training that are very focused on the evidence-based information and guidance, so much so that they forget that there's a human sitting in front of them.
Yeah,
that's where the boots on the ground thing, and why I think collaboration between scientists and clinicians needs to happen more often when we're making clinical guidelines, when we're making legal decisions on what is covered in insurance plans and pharmaceutical plans and all that. So I feel like being the clinician, the thing that I'm seeing on my side is both ends of the spectrum and the pendulum constantly swinging one way or another, and constantly trying to bring it into homeostasis back into the middle somehow.
Absolutely. Totally.
No, I totally agree. I mean, you could certainly see, someone who's so fixated on what do the data say and they forget, a very potentially critically important key detail of patient history, right? And that could lead them to a misdiagnosis. And so, I mean, in medicine, you need both of those things.
Yes.
Absolutely.
I think that's cool. And to answer the question that we started with, I think there's a wide spectrum of how doctors learn research and science in the first 2 years of medical training.
Right.
Some get a heavy lecture on it. Some get a very glossed over sort of summary of it. But then in residency training is where I see either a strong emphasis from the program where they're learning and they have journal club and they have times where they're dissecting weaknesses of articles and research that has been put out. And there's such a wide variability.
Right.
So I think it's difficult to pan down and say all doctors are not good at research or they are. And when we do say doctors aren't scientists, the problem that comes up is then the skeptics of medicine come in and use that as an entryway and say, your doctor doesn't know what they're talking about. I know the science. And most people don't have the time and the energy and the dense informational background to know the difference, as you said, between two different opinion articles or research articles. And they're left confused.
And I think, to play devil's advocate on the other side, you obviously get the people who say, I know the science, when they in fact do not know the science. And that can be true even for scientists, right? There are scientists that, we've seen it a lot in the Twitterverse where they are going outside of their field of expertise and they're misinterpreting the conclusion of a study because it's not in their scope of knowledge. And that's true for scientists, clinicians, general public, everywhere in between. So I think, that's why there has to be collaboration and that's why there has to be discussion and, constant evaluation of rigor of data that's emerging.
Agreed. And this brings us nicely to our point of how we met. Do you remember how we came to...
I remember. So
did I slide into DMs?
No, Dr. Mike.
Yes, there was a DM.
Yeah, well, kind of. I think it was me that slid into the DMs. Okay. So you were a guest, or you had a guest on your show, and you were talking about the RSV surge, and you were discussing how there was an increased proportion of hospitalizations or severe illness because there was this
timing shift.
Timing shift, exactly. What we can call the exposure, exposure gap, not immunity gap, everyone. We've covered that already. But the fact that the first time a child gets RSV is most often the most severe time. Right. And you got a lot of flack from people about that.
Actually,
from clinicians.
Immunologists. No, not from clinicians.
Oh, from scientists.
From scientists.
Whoa.
So it was actually heavy from the science community.
Very interesting.
And they were using the same talking points that you're saying right now, which is interesting and why I really want to discuss this.
Okay.
Because they were saying he clearly doesn't understand. He's a clinician, not a scientist.
And I remember I slid into his DMs and I said...
Before the drama started.
And I was like, I appreciate your take on this. And I sent him our video about,
debunking
why there are
immunity death.
why there's such a surge of respiratory viruses this season, and a lot, the multifactorial aspect of it, right?
Absolutely.
We have, the COVID burnout. People are going back to pre-pandemic behaviors. You have routine circulation of a lot of respiratory viruses. And I think, it was just like, it was like a commiseration sort of thing initially.
What was frustrating about it was that I said in opening my statement that this is one of the leading theories.
Right.
Essentially saying that this is multifactorial.
Yeah.
Right.
So,
but there's no nuance.
No.
Yeah. and then I asked you, even after the critique started, do you think I said something wrong that I need to issue a correction?
Right. And
because I want to, as a clinician, put out accurate scientific info.
So you're absolutely correct. Typically, a lot of these I don't want to say childhood illness, because of course adults can get RSV as well. But these illnesses that are typically more severe in childhood, influenza, RSV, otitis media, a lot of these things, right?
Yep.
Your first interaction with that pathogen is most often, and I don't want to say always, because
of course.
it's multifactorial.
Yes,
Things change throughout the course of someone's life.
Yeah.
But very often,
in fact, most often RSV is fine. Kids do fine with that. So that's what reassurance for parents.
Correct.
Because as a clinician, I'm also worried about the parent being worried that if they
for the most part,
RSV.
it's generally mild. But your first interaction, your first encounter with that virus typically leads to the most severe illness presentation. And so if there are kids, not that their immune systems are compromised from not being exposed to it, but it's just the first time they've seen it, it will often be more severe than the next time they see it. Now, that's because we don't develop full immunity, long-term immunity to RSV, and that's why you can get infected repeatedly. However, you have there's a lot of different components of the immune system, right? You have the innate immune system, which doesn't have any memory and it's always there to patrol. But then you have different arms of memory immunity, and some of those taper off more quickly and some do not. And so you can still get sick, but it's typically less severe in future encounters. But nothing of what you said was incorrect. There's a lot of factors at play this year.
Yeah, the immunologists were pointing out that they're saying the size of the airways changing as the child gets older is the reason for the second illness being less bad. And that's true. We don't disagree.
There's
it's one of the reasons.
Yes, exactly.
Multifactorial.
Also, general development of the immune system occurs as people age.
Course.
Right.
So, and that also goes the other direction, right? You have a peak and then you have a valley when you have immune senescence. So then older people, their immune system is less
waning,
responsive and they now have similar risk factors as you would as a younger person.
Can I just say, I think it was awesome how you went about, like, you reached out and you really wanted input and you were open to, are there any inaccuracies? And I feel like what's so interesting about what we're doing, it's so public.
Yeah.
And when these scientists or clinicians, whatever, it's like clinician on scientist violence, like they do it so publicly. And then think about what the public is seeing.
Exactly. That's my concern.
Right?
About it.
Right.
It like totally discredits everything that we're doing. It's like a journal club or a peer review process, but like in front of an audience eating popcorn.
Yeah.
Like scientific discourse is normal. It's encouraged. It's the beauty of science, right? But now that it's all playing out in the public eye, they're like, oh look, this is wrong. They can't get it together. There's such disagreement, and I just feel like it erodes public trust in science and medicine.
And also, like, when you're a professional in the field, clinician, scientist, whatever, when you're on social media, what is your purpose? You have to think about, what is your purpose? Are you just trying to have a pissing match with another person in the field to make yourself feel better or feel smarter? Or are you trying to do something for the general good of society, right? If it's the latter, then what is your point of calling someone out publicly? If you have a critique about what they're saying, message them privately. You don't need to go and dogpile them to make yourself feel better. That's completely unproductive and, as Jess said, erodes public trust in both science and medicine.
Yeah. And I think if the goal is evidence-based medicine and getting people to buy in, you should avoid that at all costs.
Exactly.
Exactly.
We have to get our act together. Honestly, like I feel like COVID really lit a fire, and there are so many of us out there who are now in SciComm and in the public eye. But like, I don't know, there's not a whole lot of kumbaya behind the scenes. At least it hasn't been for us. I don't know if I know it hasn't necessarily always been the case.
Tell me about a time where that's happened.
Well, so we've gotten a lot of messages from people who have seen people, and we're not super active on Twitter. I'll just kind of preface that. We do most of our work on Instagram, and we do have the weekly podcast. But every now and then, and Jess is kind of forcing us into the Reels world and TikTok.
Sorry. I mean,
that's where the world is going.
Right?
Yeah.
And TikTok.
Jess is just facilitating.
I want to hide my face. I'm a scientist. I'm going to go hide in the lab with my coat and my sweatpants.
You just also happen to be beautiful, and I think it would be nice to be got your face on social media. But okay, go on.
But anyway, so we have gotten a lot of messages from people who follow the podcast page because, again, our page is really geared towards providing content for the general public. It's not really designed for complex scientific discourse like let's talk about toll-like receptor signaling and how it activates interferon regulatory factors.
Yeah, I don't know what that means.
That's not.
I regret saying I was a scientist at the beginning.
So that's like the Twitterverse of like the scientist, right?
I raise you a TNF alpha.
Follow some interfering gamma. So anyways, we got a lot of messages from people who were so concerned with a lot of these articles coming out about post-COVID and long COVID and how it was leading to immunodeficiency. And people are likening it to HIV and acquired immunodeficiency syndrome. And I was like, I just wanted to alleviate people's concerns that there's no body of evidence to support primary immunodeficiency after COVID. And in fact, even these temporary changes in immune cell populations are totally normal.
All right, well, I got to set this up because what you're saying is really important.
Okay.
And if we don't set it up, this might go over people's heads because I feel it going over my head, and yet I already know what you're saying. Okay. There is a concern.
Yes.
This is the problem. We're going to set the table. The problem is people are worried that after COVID, their immune systems are going to be weakened.
Correct.
The theory is potentially kids are having worsening RSV spikes because they've been sick with COVID.
Right.
So what has the evidence shown us on a practical level from experiencing COVID to what happens to our immune systems after?
So there's a lot of different things that happen, and that's the challenge, right? Yeah. So there are some data that suggests that some of the persistent symptoms of what we're calling long COVID, which is the post-acute sequelae of the infection, can be due to overactive or hyperactive immune responses, meaning you have persistent populations of T cells, inflammatory populations of T cells that are leading to inflammation, that is then leading to some of these symptoms that people are reporting. There's also some data that suggests
so some data says there's inflammation happening after you're sick with COVID.
Right. And that might lead to...
And you might have some symptoms as a result. And then there's some data
that also suggests that some people's memory immune system is less responsive, which is one of some of the theory behind why people are getting sick more frequently with other respiratory viruses that are always circulating. And then there's some data that suggests that there are no long-term changes or persistent changes for other people. And that is kind of what you would expect after a viral infection. There are going to be some populations that have one response, some populations that have the other extreme, and then some in the middle, right? Okay. It's a bell curve. And so, unfortunately, a lot of media outlets and professionals on Twitter have kind of leaned into one of those directions and really harping on this, like long COVID is destroying your immune system and leading to immunodeficiency, and it's suppressing your immune responses.
On par with HIV.
Correct.
Really
on
spreading
par
fear.
with HIV. Like really,
a lot of fear mongering.
Yes. A lot of fear mongering. And there are very vocal people on Twitter who are doing this. And so we wanted to simply alleviate the concerns that there are no data to suggest that
it's
COVID,
that bad.
Right. That it's that bad. That there may be temporary changes to your immune system, but that makes sense, right? Your immune system's fighting a virus, so it's going to take some damage and it's going to take a little bit of time to recover, as you would expect. But people are not getting infections, opportunistic infections that you would expect if your memory immune system was basically destroyed.
Got it. So it's not as bad as people are making it seem on that lane.
Correct.
What's the other lane that some people are going into?
Well, so what happened there was that I got called out for basically ignoring all of the data that are suggesting that there is temporary perturbations when that was not what I was saying at all. And I actually noted that there were temporary perturbations. So the fear-mongering camp of COVID is destroying everybody's immune systems and you're going to be sick forever basically dogpiled me and
They thought we were downplaying long COVID.
Yeah,
that was the whole thing. Like, why are you downplaying this? Like, this is feeding into this idea that COVID is over. We shouldn't be concerned with it anymore.
We have never done that.
And this is the problem with social media. You have a very limited amount of time, right? Like, we had a 60-second, 90-second reel, and Andrea was responding to that fear, to the fear-mongering headlines, like, oh my goodness, 50% of people are getting long COVID. It's like HIV. Our immune systems will never be the same. And they came after her, and really, you're not even, it was vicious. People really going after her specifically. There were people who have pages dedicated to trying to take us down, and they were ripping into credentials. I'm sure you've experienced the same. And again, it's sort of interesting, like the medium as message, like the medium of social media is interfering with our ability. Like if you want a thesis on like what Andrea, obviously you could talk for hours about this.
150-page thesis on, but that's not productive.
Right.
You know what you're experiencing right now? And I'm only smiling because you're experiencing what clinicians experience. You're trying to take a lot of complex data.
Yes.
And you're trying to simplify it into a visit.
Yep.
But the challenge is, but the people that are attacking, the people that actually were doing the attacking were clinicians.
Yeah, there was a very angry dermatologist.
Yes.
Yes.
Well, I'll tell you why I actually agree with you on your stance. Why I'm against fear-mongering specifically, and not to downplay long COVID or the temporary changes that we see in the immune system's effectiveness post-COVID. Because the human mind is so powerful, and it really shouldn't be mind and body, it should be mind-body, that if I plant the seed in either one patient or in many patients by talking on social media that their immune system is weakened, their immune system gets weakened.
That's actually true.
Yes.
I agree with you. And okay, so this
Isn't that wild?
No,
Wild.
but it's 100% true because we know, again, multifactorial,
Word of the day.
stress hormones, cortisol, there's a whole lot of pathways that get activated,
Yeah, of
but
course.
your endocrine system feeds into your immune system. Your immune system is involved in every bodily system that exists.
Yep.
So everything, there's interplay. And this is actually a struggle I'm having with the long COVID because there is no clinical diagnostic criteria. There is a giant encyclopedia long list of symptoms that are associated with long COVID, many of which can be associated with the fact that we've all been living in a pandemic that is traumatic.
Absolutely.
And people have PTSD and people have depression because they've been locked in their home. Is that actually a consequence of a viral infection? You can't say that because there's no way to parse that out. And so all of these things are getting lumped into the umbrella of long COVID. And that is, I think, in some ways inflating the numbers of people that are reporting saying that they have long COVID. Because if you look at the actual biology of this virus, yes, it can do some damage. For sure. We have never downplayed that. We actually have a lot of posts on long COVID and COVID in general and highly encourage people to get vaccinated and take mitigation measures. But there is no robust body of data that suggests that physiologically plausible that, all of these things are going to be associated with all of these people who had COVID.
And it's like correlation doesn't equal causation, we always say. Just because it happens after you had COVID, it doesn't mean it's because of COVID or it's long COVID. And anytime we try to articulate that, people come for us because they feel like we're downplaying.
I feel like in medicine, what ends up happening is you have arguments over nomenclature. Like, what word did you choose to describe this given? When in reality, we're talking about the same thing.
Yes.
We are on the same team.
Yes.
You might think this is 5%. I might think it's 7%. But the difference doesn't matter. And I think what is created is like a very tribalistic situation where there are ulterior motives to argue about the 5 to 7% difference. And then the person that suffers in all of this is not the person like you getting attacked or the person doing the attacking, but the viewer, the average person who's trying to figure out what the heck is going on.
So out of the interest of that, we actually ended up taking down that particular post because
I feel bad that you guys did that.
Honestly, the only reason we did it, and
they were doxing me.
They were really doxing her. They were coming for her hard.
But then now you've empowered them to say if they dox you hard enough, you can do it again.
Well, no, but the reason we took it down is because we want to do a more comprehensive summary.
Well, you could have done that as well and left that one up.
No, I know this was a really tough decision. And when they make it personal, that's when because we've left all 90% of our content is controversial.
Yeah, we get
and
a lot
don't
of like
intend it to be.
sexualized death threats.
But then when that stuff comes in and if they bring my kids in or anything like that, like shutting that right down, you know?
But normally, like, we have no problem arguing, you know,
Right.
publicly or not. But it was more because the whole thread just completely lost track of like the purpose of it. It was not for some clinicians to get into a pissing match. It was, we were trying to alleviate a very specific concern that, you know, people are afraid now, right? Because the public health emergency, it's ending.
lifted, right.
Nobody's wearing masks. Only 15% of people have gotten the bivalent booster. So there are people that have a lot of health anxiety and they're afraid to leave their house. And so we're literally trying to alleviate and be like, it's okay.
Yeah.
I don't want to say it's inevitable, but right now with, you know, XBB 1.5, like it's going to spread pretty quickly. But we don't want people to have this overwhelming paralytic fear that if they get COVID, they're never going to be the same. Not to say that there's not bad outcomes, but vaccination, booster, all of those things can improve you know, improve your outcome or reduce the risk of severe outcomes.
Can I say one other thing? Please. I feel like how we try to set ourselves apart from some other scientists, SciComm pages, is that we're obviously, yes, we're scientists first, but we're also practical, and it's like real life. Like, you know, like people really came for us when we said like we're not necessarily masking all the time. Like this is when there was a real lull. It's like real life. Like I have young kids. Like we're slowly returning to normalcy, going to restaurants, and a lot of scientists and people in the SciComm community were like, "How irresponsible of you!" And it's like we're being practical.
But what's interesting there's a level of hypocrisy there from people that are pretending like there's perfect levels of protection that exist.
Right.
And then you'll even see Dr. Fauci, who's on my channel a couple of times. We're talking about appropriate levels of risk for you might not be what's an appropriate level of risk for you.
That's what we try and talk about a lot is that, you know, if I lived with a family member that was really high risk, I would be doing
changing
things
your behavior.
Exactly.
Yeah. But there's some people where it's an all or none. And initially early in the pandemic when we didn't know anything about this virus, like
of course.
I was very cautious.
I didn't leave my house for the months.
I stopped hosting group runs outside because we didn't yet know how quickly this could spread even outdoors.
My husband lived in he's an ER doc. We got an Airbnb for him. He showered outside. Like he was literally like writing his will. Like we thought it was like end of days. No one knew what was going on.
Well, that's what the problem is. They start kidnapping the information from what you said, you know, when the pandemic first started to what's going on now.
You lied.
You lied.
Right.
But it's no,
science has evolved.
It's not
That's what science is.
Like our knowledge evolved, science evolved, all those things changed.
Data has emerged.
Outside safety.
But
like
what's
a lot of things
interesting
changed.
is that there are some SciComm pages who are still like very militant about a lot of things, like the mask wearing and almost shaming. Like, how dare you go to the supermarket
Let's
without
talk
a
about the
mask?
shaming, because I think this is smart. Because let's go back to the goal. If this person's goal from a psychological perspective is to increase masking, and throughout the years of practicing medicine, we know shaming does not work. We saw it with the HIV pandemic. We see it with vaccine hesitancy. You shame, you break lines of communication, you don't help anyone.
Yep. Right.
So what are your theories as to why people are shaming? If there are evidence-based people who know shaming doesn't work.
I mean, you know,
is it emotional?
It's
yes.
Very emotional. I was going to say it's emotional. You know, they've kind of dug their heels in about this given topic, and I think it's a gap in effective communication skills. They don't know another way to communicate that someone should be wearing a mask aside from this kind of shame rhetoric.
I also feel like we're not academics. I worked briefly in clinical academia, but we're not academics. And I feel like the academic approach to the non-academic approach is very different. Like there's a lot of pride, a lot of like ivory tower type approach. And I feel like they take a stance and they just double down, you know, but I think, so I would say, yes, I think it's very emotional, a lot of pride. They want to be an expert, you know, and for whatever reason, the black and white, very bold statements, those are more impactful. Those are the things that get shared and for whatever reason. And it's so frustrating for us because we always say science is all about the gray and there's nuance. And like now I do mask if I'm going to a supermarket or whatever. And it's because there was an uptick in cases. Like things change. Like I don't see the reason that we need to double down on a particular stance. It's like, why can't we evolve? Why can't we acknowledge that there's nuance in gray? So I don't know if I'm answering your question.
No, I mean, I have a different theory.
I want to hear.
Yeah,
sorry.
but I think it's definitely there's definitely a little bit of that ivory tower.
Yes.
Because again, I did work in academic research and now I'm not. Now I'm in biotech. That's my full-time job. But now I'm also involved in, this Lyme disease foundation. And, again, the goal of that is to provide, evidence to the masses as well and dispel misinformation. And I think, academics who live in that academic bubble, they don't realize that the rest of the world, there's a gap, right? Mm-hmm. There's a gap in scientific literacy. There's a gap in understanding the granularity of things.
Trust.
Yes.
Yeah, exactly. Yeah.
I'll tell you what I think is causing it. Algorithms.
Oh, yeah. I could agree with that too.
I mean it not like this is an evil AI thing coming to get us. I think clinicians, scientists, whoever these people are that are very heels dug in, one way or the highway, have realized that if you take the stronger stance, the algorithm then will have a higher chance of recommending your content.
Totally agree.
Therefore, this is the point where I think they make the mistake. They think they're being more effective.
Yep.
Because they're saying, look, when I'm very heels dug in, I get more views. That means I'm being a better clinician, doctor, whatever. But the reality is the type of viewer you're getting there is someone who just wants to argue rather than the person's mind you actually need to change.
Right. You're becoming the clickbait.
Yeah, exactly.
Yeah. And we always say, like, just beware of any extreme statement. Like, but you're right. Like the statements like, this is going to kill you or this is going to cure you. Like those are what people want to hear. It's like, oh my goodness, here's the answer. And it's boring when we say, well,
the dose makes the poison.
Like there's sort of not exactly like sometimes that, whatever, you know what I'm getting at. And I feel like sometimes we get sucked into like, some of our posts, and I guess I'm being a little self-critical here, like I guess people now, our followers who like our nuance are like, oh no, this is a little bit reductionist. Like you came down too hard on this and there's nuance, there's middle ground. And you're right. Yeah.
But I would argue that those posts that we do, it's because we're trying to reach other audiences.
Yes.
And it's a topic that we've already done a 2-hour podcast on, that we've already done, 10 slide carousel post on. And sometimes you need to draw in, but it's never a single format or a single type of medium.
But to your point, like we're not doing this like just for fun. Like this, what we're doing on SciComm takes a ton of time and energy and effort. And the reason we're doing it is to reach a large audience and have an impact.
You don't have to tell me. Yeah, absolutely.
Listen to that. We got to take notes from you.
No, that's why I do it as well.
That's why we're doing it.
The way that I like to think about it, because everything is reductionist to me because I'm not very smart. So I have to make everything very simple.
Okay.
So when you are in first grade, I don't know when this is actually happening, the learning, you tell kids you can't subtract 5 from 2 because they're not ready for negatives yet.
Right.
And then you have a calculus professor go into this teacher and say, you're an idiot. Of course you can. And it's like, well, yeah, but they're like 5.
But you're not there yet.
Yeah, we're not there yet.
Not there yet.
So when you're making a piece of content and you're saying the end of the world is not here because COVID is happening,
right,
and the researcher, that's the calculus scientist in this example, goes and starts yelling at you, you're like, dude, I know, but like, I'm trying to get this.
You have to think about your audience
and match the level of understanding. Exactly.
And that is, I think, the challenge with the academics, because they're
teaching and communicating with other
academic bubble.
Yes.
They don't necessarily frame things in a way that's going to resonate with the public that's not at that level.
Well, and also, I don't know if this is getting off topic, but like the different platforms of social media, it's like they're totally different. So we're big on Instagram, which is you have an infographic, you have 10 slides and then a caption. On Facebook, it's all, what seems to do
more
better is more text heavy. If you're on TikTok, it's a video. What was my point of this?
Twitter?
Twitter?
I don't know.
That some of them are different in terms of effectiveness or anger?
Well, and so what Andrea was getting at, like on Twitter, a lot of academics, like really they get into the details and it's like academics talking to academics. On Instagram, we're using infographics to
we're not trying to talk to other academics.
For the general public.
Yeah.
And then when we like cross post, that's when we get
into trouble. Yeah.
Exactly. Sorry, that was
we don't spend a lot of time on Twitter, but like I'll go on Twitter and it's like, you know, very reputable immunologists who are literally dissecting a paper and going through all the different cellular pathways and the inflammatory cytokines and the different populations of T cells. And it's like, that's cool. But again, what's your goal? Should that be in a med-sci room on Twitter? Like, should that be in the main feed? Like, is that adding to confusion to the general public? I think it is. Because I think what our role should be as scientists and clinicians is communicating to the audience that needs to hear it. You know, we go to conferences around, you know, throughout the year where we can get into the nitty gritty, the granularity, the presentations, every single cellular process that's happening. We don't necessarily need Twitter as a forum for that as well, you know?
Right. And we're focused on the takeaways, like what's going to have the most relevance for for the public. This is we're not speaking to peers necessarily, right? And we always say like, I call an architect if I want to build something. Like I'm not saying I'm better than anyone because I have a doctorate, right? But we have very specialized expertise. We went to school, we trained for a freaking decade. You know what I mean? Like we can't communicate all of the detail in all of our posts. So our goal is to distill it.
Yeah.
Anyway.
No, there's never been a theory or concept presented at a medical symposium that's not met with some level of debate.
Yeah,
right.
But if that level of debate happened in the public every time, it would make people very confused, and that's what's playing out on social media.
And nobody would trust science or medicine as a result. And we're seeing that erosion in a very concerning rate right now, I think.
Which is why I am trying to prep the audience and educate the audience that this level of discourse is to be expected. That's my new thing on the thing, on the channel, is to get people to say, okay, here's what I'm saying, and expect a level of pushback that not everyone will agree with what I'm saying, and here are the reasons for why, to hopefully, the same way that if you're making a marketing campaign, you're telling the brand, hey, I will do this. 90% of people will love my post, but then 10% of people will absolutely hate it. You're prepping them for the potential negative feedback. Same thing for the audience when it comes to medical knowledge. And I've seen this play out on Twitter with some infectious disease docs that I'm friendly with, up north in Canada, and they're getting absolutely destroyed for things that they've said in the news unfairly when they're presenting a very balanced, nuanced approach, and it's not one way or the highway. Exactly what we've been talking about. Let's move off actually the pandemic, because I think it's people are probably
they're tired
pandemic
of
tired. There are 3 subjects that you guys wanted to discuss today that you're feeling is very prevalent in science communication, maybe in the health, wellness, woo-woo space, dare I say.
Yeah.
What's one of those topics?
So I think the first, and actually, you know, this really kind of goes back to a lot of what we've been discussing, but it's the concept that, you know, people will co-opt a legitimate scientific term, something that's happening on a cellular level or an organism level, and they co-opt it to explain away a whole slew of ailments. And, you know, one of the terms of the day is inflammation, right? So inflammation is a normal process of the body. It needs to happen for
many
life,
reasons,
for life. It's balanced by the anti-inflammatory responses, but you find even scientists, even clinicians, definitely the general public, definitely like the wellness influencers use it as a way to explain or create in some ways new medical issues, right? So, you have GI issues, it's inflammation. Oh, you have brain fog, oh, it's inflammation. Oh, you have this, oh, it's inflammation. Like, it's not, again, nuanced, multifactorial. If you didn't have inflammation in your body, certain cellular processes would not exist. Every time you literally consume something, you generate inflammation because you're breaking down a large molecule into smaller molecules. That's a catabolic
Are you
process.
launching a PR campaign for inflammation right now?
Yeah, do it.
You're like, inflammation is not always bad. No,
Well,
is
no,
that true?
it's true. It's true. It's
so you're
absolutely
saying
true.
people have villainized inflammation
Yes.
to make it like a buzzword for every condition.
Correct.
And while it's true, inflammation occurs in a lot of those issues.
It's always balanced.
Yeah, it also occurs in other things that are very good.
Yeah, and also like the most inflammatory thing that you could do as a person is exercise.
Yeah, exactly.
So,
or get an infection and need inflammation.
Inflammation to counteract. Yeah. So, it's very frustrating as an immunologist because, that, a lot of the other buzzwords that come along with it, like autophagy and free radical, like these are all like words that have meaning in science, but
they're sexy words.
Yeah. But don't have meaning when they're being applied in like the health and wellness space. And it's leading to a lot of like cropping up of faux medical diagnosis, a lot of pseudoscience, and of course it's preying into these
something
people.
down. Give me some pseudoscience diagnoses.
Well, so like the leaky gut syndrome. Okay. That's one that is often.
What do people say about leaky gut? Let's define it for the audience.
So people are claiming that leaky gut syndrome is an issue where your intestinal cells become permeable so that food bits and toxins are leaking out from your GI tract into your bloodstream and are leading to inflammation. And that's why you have all these symptoms: fatigue, lethargy, brain fog, headache, bloating, diarrhea, whatever, like every symptom under the sun.
Fair.
So intestinal permeability is a scientific term because your cells are not cemented to each other. They have little junctions, little proteins that are like little gaps, and that actually allows the transport of nutrients, molecules that you need, but it's not allowing food bits and bacteria and toxins to leak into your bloodstream. And so again, scientific term, got co-opted for the wellness, and now they're diagnosing this or self-diagnosing it and then selling supplements to cure your leaky gut because it's all due to this inflammation.
Got it. So they've kidnapped the word inflammation, created a condition called leaky gut that people have real symptoms for. And instead of getting the treatment and diagnosis of what their symptoms are coming from, they're getting this faux diagnosis leading them to missing the proper treatment, which is the big problem.
Yeah. Okay. And that's the big problem that I have is that, they're getting preyed upon by these people that are making a profit.
Well, that's the thing. They're all vilifying pharma and industry because it's for profit. What do you think the wellness industry is? I mean, everything. I'm sorry. Are people so naive? Everything is for profit. Like, we don't work for free. I don't understand this concept. It's the most frustrating thing in the world, and love to talk more about that. But so then it gets co-opted by the wellness industry. And my big thing, I guess, related is this natural and the appeal to nature fallacy, and that everything that's natural and clean is automatically better for us, and that anything that's synthetic or made in a lab is just it's bad for us. It's toxic and it's full of chemicals. And we always say everything is a chemical. And of course, that's not true. And the example we once gave is that, was it willow bark?
Yeah,
what is that thing?
Salicylate.
There you
which
go.
is now, now we've synthesized it into aspirin.
So people were chewing on willow bark, eating willow bark for pain relief. And that was great, but they were, pooping their brains out, vomiting. There were all these GI side effects. And now we're able to concentrate it in a lab, get rid of all the stuff that was making people violently ill. And also, spoiler alert, by synthesizing things in a lab, we're preserving nature because we don't need to destroy nature. We're able to. So I just don't understand. I feel like we're, as a society, moving towards this idea that everything that's a drug or synthesized or made in a lab, manufactured, is automatically bad for us. And this wellness industry, multi-billion-dollar, booming, based on this premise. So that's my
and the reality of the wellness, quote unquote, wellness space is the supplements they make are
not regulated by the
well, yes, but
they're synthesized.
Specifically, they're synthesized and purified in the same ways that
they're made in the lab.
No, not even in the same ways. In worse ways, because there's no oversight,
no quality control.
Exactly.
And that and like so like the appeal to nature fallacy. I mean, it's everywhere, right? Like, I only want all natural ingredients. It's like, well, arsenic is all natural too, and botulism toxin is all natural too, and again, those have higher toxicity than a lot of synthetic things.
So I have someone in my family, I'm not going to say anything more than that, who was just diagnosed with Graves' disease.
Okay.
And, her whole thing is that she does not want to take any medication for it because it's synthetic. And she only wants to go on the, the AIP, the autoimmune
protocol diet.
She's going gluten-free.
Which we've covered on our podcast.
She's going gluten-free, dairy-free, and she's only doing homeopathy. I mean, you as a clinician, like, I'm sure you deal. I'm sorry, I'm asking you a question.
Yeah, but ask me a question.
But like, how do you deal? I'm sure you get a lot of people who come in and are like, oh no, I don't want to treat that with medicine. It's toxic. It's bad for me. I want to treat it naturally. I mean, do you get that a lot?
All the time, in ways on both sides of that equation.
Okay.
So I'll have people come in and say, I don't want the pill for this. I want the natural approach. And then on the other end of the spectrum, I have me saying, you don't need antibiotics for this.
And they're demanding,
Yes. We talk
Or
about
I'm
that.
depressed and I'm like, okay, well, we need to do some therapy, some
Right.
talk therapy.
And they're like, no, just give me
I
the
want
pill.
the pill.
Yeah.
Right.
So it happens on both ends.
Right.
For sure.
Which is why the pendulum, again, I'm trying to bring it back to the middle.
And it's multifactorial because, it's like I want to tell her, we're not saying that you take a pill for everything. I mean, a medication helps people, all the time. But yes, there are other things, other factors, other lifestyle changes that we could make. It's not like we're saying you take a pill, you take medicine, it'll fix it. And then to your point, you're right. On the other side of it, people, like I know my best friend's a pediatrician, and she said, like, parents come in, they want to leave with a prescription. You want to feel like you're doing something tangible to make your child better, yourself feel better. So they're prescribing medications and antibiotics even when they know this is viral and antibiotic is not going to do anything.
Yeah. Another one of my friends, actually, it was he was a med student when I was doing my PhD, and we taught clinical microbiology to the second year med students. And he's an emergency room physician in Arkansas now. And he was like, I'm guilty of prescribing antibiotics when I know I don't need to, because they come into the ED and they want something to leave with.
And you want a good DLQ.
Yes.
Yeah.
Well, the way that I try and position myself in times where a patient might come in and want something natural or have a distrust of the medical system, I try and put myself in their shoes as much as possible and figure out what is the cause of this.
Yes.
And as a person who's experienced a decent amount of life in my young age of 33, I have still seen what they have seen, which is doctors don't spend enough time. They want to make a quick diagnosis. They want to throw a pill at it because we don't have the time to discuss lifestyle modifications, to debate lifestyle modifications, to see if the patient is actually doing this because we don't have enough appointment slots available for follow-ups. So as a result, I get why people believe in the naturopathic cure, so everything better than the modern system.
We talk about this all the time.
Yeah.
Like,
the healthcare industry has a lot of flaws, and that's a topic for another.
And people are suffering. There are chronic issues. There are major problems with our healthcare system. And I hate when people come in and are fighting with my husband and blaming him. It's like first of all, he's getting chastised from the higher ups, from the administration. Move fast, see as many people as possible. He wants to spend more time talking to his patients. So we get why some people are drawn to like naturopathy and chiropractic and, stuff like that. And we just want to educate people like, okay, we understand why you're drawn to it. There are problems, but the evidence is just not there to support it. And if you're foregoing actual necessary medical treatment and care, that's the problem.
Right.
You want to put onions on your feet? That's fine. If you're sick, that's fine. But if you're not getting your kid an antibiotic, if they need it for a bacterial infection, that is a problem.
Yeah, this is where my sort of clinician hat gets put on and my scientist hat comes off, because guidance general for the population might be, okay, get this patient, thyroid replacement medication, but patient wants to do this unique diet. The treatment says only do the pill, not the diet. But now for this patient, I will try and find some level of middle ground.
Sure.
Where, okay, maybe we don't have to take the dose that I was going to start you on. Let's start on a lower dose, recheck, and make some. This is against what the evidence shows.
Yes.
But I'm doing this with the
you
knowledge.
want to get trust.
I want to get trust.
You want to get buy-in.
Make my way to the time.
Because presumably you know, or at least have an inkling that the other modifications are not going to be as effective. And so eventually you're going to have to get them up to that dose, but you have to take baby steps because they're not there.
You're being practical and realistic. You want some adherence, better some medication. Let's start them, than just having them completely say, okay, this doctor is not listening to me at all. He's not hearing me. He's not.
And we want to be heard.
Right. Exactly. So we totally get that. Andrea, you sometimes though, and I love to talk about this, like the slippery slope, like we sort of try to figure out like, do you want to talk? Is it okay if we talk about that? Yeah. Okay. How sometimes people will come for us. It's like, well, you can't say blanketly that like, chiropractic is bad and acupuncture is bad and all this and that. And like, it's true. Like there is no evidence, right? So we don't want we're not condoning it because there really is no evidence to support its use. But then if we say like, don't do it, it's not helpful, like people
so
shut
we try
down.
We try to, approach it from like a risk like there are some legitimate risks with X, Y, or Z.
Right.
The data don't support it.
Right.
We've done a lot on the placebo effect, which, we kind of discussed earlier on here that, if people believe that they're getting something that's going to help them feel better, and sometimes it can also contribute to that. And a lot of people, they're like, well, I took the supplement and I felt better. And it's like, well, you could have been at the end of your infectious illness to begin with. And so it's just a matter of time. But we're trying to get people to think more critically about those sorts of things. And, the wellness industry plays on this like desire to get a quick fix, right? They're like, well, you're going to take this, that, and the other.
The reason why they're quote unquote winning is because the wellness industry, you're requiring people to think critically at a time where they're exhausted, they're tired, they have a lot of stuff going on, and maybe they don't have the health background to know.
Right.
And then the wellness industry is simplifying and asking them to not think critically and saying, here, we've already solved this for you.
Just take this.
And then we expect people to be like, wait, why don't you agree with us?
But what's interesting, and I would love your thought on this, is that, so you said, you have people, they come to you, they don't want to take a pill. But then the wellness industry packages up a pill of herbs or whatever and are like, take this pill, and they're much more inclined to take that. That's
what I would explore. That's what happens in my visits. So just my last guest on the podcast was Angela Johnson-Reyes, and she was telling me about how she prefers this naturopathic approach. And it would have been very easy for me in that moment to point out and say why her thing isn't proven to do what it's doing for her. But what do I win by doing that outside of making myself feel good that I'm morally superior or not morally knowledgeable superior, whatever? It gives nothing to the conversation. So instead, the conversation changed to what happened that she went this route. And she started telling me all those stories of doctors neglecting her, not answering her questions, jumping to medications, giving her an antibiotic when they were like, I don't really know if you need an antibiotic. And now all of a sudden, I can then create some education, not even in the moment of where we disagree, but in general, why my mindset is negative on an industry, higher on this industry, and we can create a level of common ground instead of constantly putting stones in our path.
Yeah. And I think, it's a broader issue. Like, we know there are flaws in the healthcare industry. Often scientists get conflated with the healthcare industry, which we're typically not, directly involved with. And clinicians often get lumped into the category of, I had this one bad clinician that ignored my complaints. They didn't believe when I said my pain was at an 8. They didn't do this. And then that leads to a general mistrust of all healthcare providers, which is a whole other, issue that needs to be addressed.
I don't think that's unreasonable.
Yeah.
I think if you've been in one crap situation and then you're put in that same exact situation, the fact that you're experiencing the same set of feelings that you did on the previous one is almost human.
Yeah.
And for us as doctors to not believe it or be confused by it is weird.
Right. Well, people always have risk aversion and aversion to negative experiences, right?
Exactly.
Like, think about, like, you go to a particular type of food restaurant, you had a really bad meal, like, the next time you're thinking about a restaurant, like, you might not even look at that type of cuisine, not even just that restaurant, right?
That's how the mind works.
Yeah.
And we've seen that even like in animal mouse studies or rat studies. Being someone that has studied medical history to some degree, mostly for the YouTube channel, not because I'm smart again, I've seen how science gets really overconfident at times.
Yes.
And I have to be open to the idea that things change, and not just data like improving, but also breakthroughs in how treatments that we once believed to be really good are not really good, or something that we believe to be bogus actually got some proof behind it.
Yep.
So when I hear like the topic of, let's say, acupuncture come up, and I have a patient who's trying to skip surgery because we've seen negative outcomes in their specific instance with musculoskeletal surgery. And they said, I've tried physical therapy, I've tried epidural injections, I've tried this. Do you think I could try acupuncture? I think it works. And they try it. I, in this situation as a doctor, have to think about, okay, what is the risk of them trying acupuncture and not overplay the risk?
Yeah.
Because it's very easy as a doctor to be like, this is risky for no reason.
Right.
It's not risky for no reason. Even if you believe acupuncture doesn't work as a doctor, there's a 30% chance it'll work because of placebo effect.
Right.
Now you have to think, if they can get a 30% benefit from this, that they believe in acupuncture, what is the true risk that they're experiencing? And the risk is quite low. So that's why I say, I think it's worth a try.
Well,
But would you agree with that?
Well, so, we actually did an episode on acupuncture. Okay. And I, our general conclusion when you look at the evidence is, yes, the risk is pretty low. There are some documented really severe adverse events like pneumothorax because the, needles are placed inappropriately. But if you look at kind of like the realm of pseudoscience, I guess we can kind of lump that into that bucket.
We're going to get attacked for that.
No.
Yeah, I wouldn't put acupuncture
maybe
in
not.
Pseudoscience. Pseudoscience is made up.
Yeah, that's true. Okay. So alternative therapy. Yeah.
Integrative.
Yeah. In the bucket of all of those options, the risk of acupuncture is low. And again, there could be a potential benefit per placebo. I think there was a little bit of evidence that for certain particular conditions, especially when coupled with other modalities like physical therapy, it actually did have a benefit. And I think if you are an individual and your option is invasive surgery with long recovery and maybe trying this for 8 weeks, and the risk is low and you make that personal risk assessment.
That's why I don't destroy integrative therapies. Simply on what you just said. Mm-hmm. And there are doctors in this space who will say never.
Yeah.
It's quackery, they'll downplay. And I understand where they're coming from. But at the same time, I got to think of that practical implication that you just referenced.
Yeah. It's so interesting because I feel like we're now kind of labeled as like the bitches of Psychology, and like we like I'm sorry.
You're unbiased science, not bitches of
I'm not self-labeling, Andrew. I'm telling you, people call us this, and that we've just like shoot down anything that's alternative. And I need people to understand, like, it's because we're coming from the perspective of scientists, and there's not a whole lot of evidence for it. And you, as a clinician, I understand why you're maybe more open-minded to it and trying to establish a connection with the patient. You don't want them to shut down completely, and
you need them to buy into your recommendations.
Context is different. From an evidence point of view, there's not a whole lot of evidence for its use. Right. And I worry
as a population.
Yes.
But then what individually?
Exactly. And we're working on a post about clinicians versus scientists and how it's individual versus population.
Right. Well, exactly. And people don't we're describing, our goal is to describe the average. And yes, there are outliers. I don't know. It's such a different world, different world. And I think
it's also a different end goal, right?
Yeah. Yes.
It's a different end goal.
Yes.
So the approach will be different.
I don't want us to be seen as like just being anti all these things. It's just that we're trying to educate people on the available evidence. And then, but by the same coin, it's like, are we also eroding then the impact of the potential placebo effect by telling people,
No, I don't think so. I don't think it's that dramatic.
No, because I think,
I think your job is to be unbiased and fair.
And so I think most people are like, yeah, we get this. And we always try and balance it with potential risk. So like if the potential risk is low, then, that's fine. But like a lot of times it's like, well, you don't need to waste your money on this supplement because there's no evidence to support its use. And a lot of it is like, people are spending thousands of dollars on these things that are being sold to them on social media.
And our issue, we're not judging the people who are taking these things and trying these therapies or whatever, alternative therapy, because again, I understand, I saw my dad struggle with emphysema and cancer. And we were thinking are there, for a time we were thinking okay, the treatments aren't working. Should we explore these things?
Outside the box,
I understand that mindset of desperation and of chronic pain and fear. I get that. Where was I going with this? I lost my train of thought.
About balancing it with
evidence. I don't know.
And not judging the people.
Sorry, thank you.
Yes, we're not judging the people. It's about the industry that's preying.
Thank you. I'm sorry, I do this all the time, and she has to finish my thoughts. So we're not judging the people, but I think oftentimes people come at us you're being so rude and you're judging us and you're. No, it's the industry and the charlatans and the snake oil salesmen. That's what frustrates us. They know there's no evidence.
The way that I pose it to someone who is a firm believer in supplements and believes that they work for all of these issues is if you walk into a supplement store, there's a supplement to cure aging, there's a supplement to cure ugliness, there's a supplement to cure sex drive, and yet we're all suffering with those things. And every person in that store still has all those
Yes.
So that's my thing. I'm if it worked, then everyone in the supplement store would be the strongest,
they would
fastest,
be gorgeous,
having the best sex,
invincible, and
living forever,
no gray hair. Yeah.
So I hope that I can just induce skepticism on that point alone.
It's a great tactic. And we try and approach it, okay, well, this is the evidence, if this was, there's a reason that they have to use these buzzwords, right? There's a reason that they have to sell it in this way because there isn't the data to support it.
And we're not in front of a patient like you are. Like, it's different for us when we're presenting information. Like, we don't have that same relationship with people. So I really do understand like what you're saying, and I respect it.
I think what we're all coming back to the point is that this is a collaborative effort. I'm not going to try and run scientific rigorous trials because I'm not good at setting up those trials. And on your end, making the deduction on which individual level to make these recommendations probably doesn't make sense either.
Right.
So
that's not our
that's
place.
why we team up to do it in that way.
And that's how it should be.
Yeah.
And it's unfortunate, you know, and I think social media certainly has accelerated it, but the pitting of each other against each other is
I think a good title for this podcast is like Doctor versus Scientist.
Ooh, oh gosh. Okay.
That way it sounds a little salacious. But
but it's not actually.
it's quite unified. I was going to just share a quick story of how, for placebo effect to work, you have to believe in it and all these things that we know. Well, I never believed in acupuncture, and I had a torn labrum in my left shoulder.
Oh, me too.
Really?
My right though.
Okay, so
I had
left.
surgery.
Ooh, okay. So here's what I did. I had this issue for 3-4 years, probably from being a goalkeeper landing on an outstretched arm or maybe bench pressing incorrectly. And I had it for a long time. It never really went away. There was maybe a day that it wouldn't be so bad, but it would constantly lock and catch. And then my dad took me to his friend who's a pain management doctor who also did some acupuncture. He did one session and I didn't believe in it. I was like, what is this ridiculousness? I didn't have pain for 10 years.
Really?
And I don't know how to wrap my head around that as a physician who I can't understand the pathway of how this worked. And then I had a same instance. I had a medial epicondylitis, not tennis elbow, golfer's elbow from boxing. And I'm like, you know what? This has been going on really long. Let me try acupuncture because it worked for my shoulder 10 years ago. I went, first session, 85% relief of symptoms despite physical therapy failing, meloxicam failing, all these things that I tried. And then this is where it gets tricky. I went for the second acupuncture session for the elbow when I probably shouldn't have. It was already so much better. But the person said, come back for a second session to make it 100%. He hit my nerve.
It got worse.
And I had ulnar nerve neuropathy that was terrible for like 6 weeks that I had to seek second opinions for. My nerve was lighting up. So it goes to show.
Yeah.
It can
The
work.
risks are not.
And the risks are there.
Right. So I'll tell you my story about so I used to be a competitive judo player.
Okay.
Player?
Yeah. Is that
fighter, whatever.
fighter?
Yeah.
Give yourself the
judo.
credit.
Fighter. I used
Fighter.
to beat the crap out of people.
Okay.
Don't mess with Andrea.
She's like, I was a player.
And so I tore my labrum. I was going to throw somebody and, my arm was here and their body went that way. And anyway, so it was like an acute slap tear and I didn't want to get surgery because, I knew it was going to be an impediment and I did physical therapy and it helped a little bit. And then I postponed it for 10 years probably. And then it got to the point where my biceps tendon basically
started suffering
completely
as a result,
frayed. And so they had to slap it all together again. But I ended up finally giving in and getting the surgery in grad school. And so I remember I was in my sling and I was pipetting I'm a lefty. So it actually, but I drove stick shift and I had to trade cars with my dad because I couldn't shift when I was in a sling for a month. But I didn't try acupuncture. I just tried physical therapy and it wasn't enough.
Imagine it worked.
Did it work?
Imagine it worked.
Oh, imagine
it worked. You could have saved the surgery. You could have pipetted.
I could have pipetted with both hands. But yeah.
But it's interesting. And I also had the same thing happen. And I'm also an osteopathic physician, so I'm a DO. So we have some extra hands-on stuff, but none of it is magical. It's all based on physical therapy-esque reflexes of the human body. And we see people get better from things that they really shouldn't be getting better from all the time. I had Osgood-Schlatter growing up where I had this inflammation below my knee. And that's very common in young folks and adolescents to experience this. And it hurt for 4 years. Every time I played basketball, it was a chronic issue, whether it was Osgood-Schlatter or jumper's knee, same thing basically. And I saw KT taping was getting hot. And KT taping
it's very popular
looks
in the
very
running
magical. It looks cool, different colors. It got me excited about it. I was young. I was 21 at the time. I put on KT tape. I did it the way that they said for the knee. And I wore it for 7 days, showered with it, all of it. it never hurt again for the rest of my life. I need an explanation. I didn't believe in it.
So I started taping my shoulder after.
What happened, evidence-based medicine scientists?
Well, it was during the same fanaticism when there wasn't evidence.
Okay.
But it's sticky tape, right? It's sticky, stretchy tape that, and they were like, well, it might, if you tape it tight enough, it might help hold it in place when you're recovering post-surgery. Yeah. And it's so popular with the elite runners now. But yeah, there's not a lot of evidence behind it. There's not a lot of explanation as to why it would help behind it.
It cured me. How?
See, it didn't cure me. Oh, okay. It didn't cure me.
He wants an answer. How did it cure him?
I
don't have an answer either.
That's your
That's my humility of medicine has to be like, okay, like, look, it cured me. And I would be the first person that if a patient brought that in, I'll be like, come on. Right. But it cured me and it worked. So like I have to be.
What color KT tape did you pick?
It was just black. It was basic. It wasn't even fancy.
Science needs that humility too. Yes. And like we've done posts like science isn't perfect,
Yeah.
So
because it's sexy to say trust the science.
I know. We used to use that hashtag trust
the science. It's
beautiful,
also sexy for like a wellness influencer to say like, all food is toxic and poisoning.
Well, everything is toxic depending on the dose.
At the dose.
Oh
my goodness. Well, there's a post that we're going to be debunking soon, and it's like,
sub in for all your organic counterparts because they're non-GMO.
Right. Well, so they show all these things, and the takeaway is eat organic because this thing has GMO. This has red dye. So what?
None of those things are detrimental.
Yeah. Why are we vilifying these things? So, but anyway, again, I don't even know why I said that. I keep losing my train of thought.
Don't vilify the things. That's it.
But no, there was another
humility.
Point. Humility. Science isn't perfect. I don't know. Anyway,
and science is sexy.
Science is
sexy.
Because it's sexy to say those things and just it seems
to create uproar. Wow.
Right. And this person has 1 million followers on Instagram. It's getting reshared, and then we have a very boring post about how GMOs are not inherently bad and how dyes are not and. That doesn't get shared 1 million times. It just doesn't because her post is sexier. So we have to figure out how to make science sexy.
Well, maybe this is not the solution for you, but this was my solution for society that I could come up with. I have been able to get a pretty big social media following with never straying from evidence-based recommendations on the channel, which is almost unheard of because most people who are medical influencers who have millions of followers are usually sharing some kind of BS.
Right. They're hawking a product or
Yes,
something.
exactly. They're doing that. That's like that Dr. Oz thing that constantly comes up.
Don't even get me started. I live in Pennsylvania. He's not even from there.
Your struggle. And I've also, to be fair, when I was a resident, he invited me on his show and I went on to talk about a program I piloted in my hospital with doctors working out their patients. So at least like he gave the evidence-based doctors a chance sometimes. So I'll just say that.
Once upon a time, he was not
he was a great cardiothoracic surgeon.
Right.
He trained in my hospital and there's countless physicians that said he did amazing surgery. So something happened.
Right. Yeah. Something happened.
Something changed. Evidence changed and we learned.
Or the greed.
Meaning our evidence of what he was doing. That's why our judgment changed.
We both were like on you.
And I decided to create a course for professionals, whether you're medicine, a lawyer, a bookkeeper, and you want to put out evidence-based good info, and you don't know how to do it through media or social media. I kind of created a playbook of how you can do it and be successful. That's my thing. Because otherwise, what I see young doctors doing is either selling out to the bunk and selling the nonsense miracle cure stuff, or they go into this, I'm going to do call out culture and join TikToxic and yell at these people.
Sorry.
Yeah, no, I hate. I mean,
I feel like don't do that. There's a middle ground.
We don't want to
be successful.
We don't want to do
financially well off.
Yeah.
You can do all.
We get offers all the time. This is what I wish people understood. Like, oh, you could make so and so amount of money if you push this product. And
we're like, no, we're not.
We're not going to do that.
But if the product was good and evidence based, we would do it.
We would.
And there's nothing wrong with that.
Well, the public thinks there's something wrong with it. I know we know there's nothing wrong with it.
And we've all like we have to make a living. Things that we've been, that we've partnered with companies.
I have to make a pause again. I think scientific minds are corrupting you right now. Do you really think all of your audience is upset when you make money?
No.
Not all of them.
It's the
how many of them percentage wise?
I think it's a very small percentage.
Exactly. So why are you upset by it?
I'm okay.
I get upset by it.
Jess
Why?
gets upset.
I'm a people pleaser. I don't know what's wrong
you
with me.
can't please
and I tell
100%.
her,
And you know what it is?
to stay off comments
Because I know how pure our intentions are, and like
it hurts her. It hurts her as a person.
No, it really does. It offends me because we could be making the quick cash. And like, I'm going to be real with you. Pfizer and Moderna, they have foundations. We talk all the time about vaccines. We have not taken a penny from Pfizer and Moderna, but like, it's like if they have foundations and we could apply for a grant where we are getting funding to do the SciComm that we're now doing for free, why should we say no to that?
Yeah.
And I don't like, that's my struggle.
You know, and the thing is the critics are going to be the ones that are going to dogpile and comment, and you know, it's going to be a very small proportion. And I try.
They're the louder.
Yes, they're very. Yeah, they're loud and they're the minority.
Effective because we're humans and we have a negativity bias.
So I try to tell her, turn off notifications, don't read the comments.
Like, we don't eat, we don't sleep, we don't shower. We both have full-time jobs. I sometimes
Okay.
and
I eat
whatever.
ice cream daily.
No, yeah. But my point is like I just
My Doctor.Mike turned on real
knowing what goes into what we do, it hits a nerve in me, and I don't know. I have to stop myself from doing that. And also,
she has to stop reading the comments, is what she has to.
But also, we should be compensated for our time and expertise, and so
I think this is the reassurance I'll give you because I am same position as you are.
Okay.
I get very upset when I read the comments. Sam frequently tells me never read the comments. Mike, stop reading the comments.
Smart man.
There was a period of time where I needed to literally go to therapy, and part of the advice of the therapy was to at night not read comments. And my critique of that advice was initially that that's avoidance behavior. We shouldn't practice avoidance behavior.
Right.
And she taught me
Mm-hmm.
that avoidance behavior done recklessly could be problematic.
Sure.
Right.
But if it's targeted at something that you see as a problem for you, it might be a good behavior and a good coping mechanism.
Yep. I've actually taken the practice of not trying to get off social media like after 8 p.m. Like my job, I often work long hours, and so I will be online officially, you know, in the evenings, but I've started, especially recently, just staying off. And sometimes Jess will like screenshot a comment or a message. And often I just don't even acknowledge them anymore because it adds to my anxiety. And I have to disconnect. Otherwise, like, I don't sleep. I already take trazodone to sleep.
Yeah. Right.
And I have to shut that part of my brain off.
You don't know how many times we've considered like just shutting down the page. Like it's like this is just.
Please don't.
You know what it is?
We need you.
It's tough because
us simple clinicians need the smart
our
scientists.
name is not helping us though. Like, and I love our name.
I had a really clever name when we first.
What?
Well, I wanted to do like a play on like, you know, show me the data, or like there was like some other. Remember, like
I
once
thought I came up with show me.
I don't remember, but there was a bunch of ones that we were
Judo match.
that we were
I would
throwing
lose.
around.
Very much lose.
but you know, we had to also factor in the fact that it was her data analytics firm that was kind of, you know, bankrolling the podcast in the first place, and you know, there were other people involved in some of the decision making, and so we couldn't be as witty or, you know,
Well, and also trying to find like we are in two very different scientific fields, so trying to like find a common ground.
Like I wanted to do some like
she had some things. I was like, I don't know what the heck you're talking about. Yeah, I don't know, like whatever. Anyway, you hear she talks. She's a very technical. That's why we're a good team. I'm more big picture. So what do you think? I'm curious for your input. We're unbiased science. And all the time we hear more like biased science. I mean, you don't even know. What if Moderna and Pfizer, their foundations, funded us not to, you know, get the Pfizer bivalent. We would never do something like, we just wouldn't do that. But to help fund our education efforts, should we take it, or would that be like SciComm suicide? I don't want to put you, I'm putting you on the spot.
For you, it might hurt, but in general, no.
Okay.
Meaning for you, knowing your personality as you've shown it today.
Oh, me personally.
Yes,
okay.
It might be hard for you to function in that space now.
Okay. But what about
like for
individual?
me, though?
So individual general advice. No, it's not suicide.
Okay.
Yeah.
Okay.
Individual advice, might not be great.
Okay.
That's my clinician.
Okay. Because I feel like we would be very transparent. Like
I would be fine with it.
Anytime we do a sponsorship,
you're very clear.
It's always like
she sometimes is over.
I know. I think I see. Like we just did. I know. I don't want to talk too long, but like we just did a podcast on infant feeding. We brought on 2 pediatricians. we all happen to be scientific advisors except for Andrea, for Bobby, but we're Bobby Labs, which is the scientific arm of this formula company. They didn't even pay us to do the podcast. There was no payment. There was no script. It was just, I felt it was important to disclose that we do have this advisory relationship with Bobby, because I had, people look us up and they're like, oh, look, formula shill, there's a relationship. So I maybe over disclose.
Yeah.
There are people.
5 people.
Yeah,
okay,
five people.
Right.
Who are you educating?
Right.
Who are you educating?
Okay, so maybe I'm over disclosing. Okay, this is
No, you're not over disclosing. Good. Do this when a scientist at a presentation.
Disclosures is fine.
Yeah, you went
always
to
do have
so
to
many
disclose.
of these
but
things.
But I don't think you have to go and explain it away.
You don't
in
have
the
to fall on the knife.
Yeah, you don't have to. You don't have to follow it up with like, okay, we didn't take a penny, we didn't do just say it.
Short of giving a copy of the agreement to the public. Like, I've thought about that. Like,
don't need
literally,
to.
no one
No,
is
you
getting
don't
us
need
a
to do
script.
that.
We are in control of everything we're saying. We didn't even.
If you were shady, the audience would know.
Yeah.
Okay.
And when I say the audience,
And
that's
also,
the majority of the audience.
Right. And you have to remember like how many followers there are versus how many are the people that are
Comments,
actually dogpiling in the
therapy
comments.
session.
No, it's
Thank
very
you,
hard.
Dr.Mike.
It's very hard because I struggle with the same thing. That's why I can speak to it this much. But I even just did a campaign right now with like the COVID-19 vaccine project, where they reached out to us to do sponsored posts for the vaccine. I'm like, I don't want to take money for the vaccine, not because I'm high and mighty, just because I don't even want to create that relationship for people. So I said, I'll do it. You could use my image. I'll post about it, but use the money to buy space in newspapers or billboards or whatever it is to put the message out there.
Got it.
So like, you don't have to fall on the knife every time.
Well,
you just
you
have to
know-
be forthcoming. And once you are,
And
you're an
are.
open book,
Yeah.
people will see it. It's like when you step into a room with someone and you spend an hour with them, how soon do you know they're full of shit?
Immediately.
Yeah.
That's what your audience is doing. So you don't have to worry.
And
if
there
you
are-
make a mistake, it's okay.
Right. And there are people that follow just to be a troll. And those are going to be the ones,
so mean.
So you don't have to engage with them because that's just giving them energy.
Tonight, we're doing a partnership with, it might be the group you're talking about.
the COVID Vaccine Equity Project.
Oh, yes, that's the project.
Yeah, so the AAFP board chair, Sterling Ranson, he's going to come on and chat with us.
So they get funding from...
They get funding from Novartis.
We were in fun. But again, like, no one told us what to say. We're just educating the public.
And we're just having a discussion with,
of course, people focused on that, and we had
It's
some
not people.
comments.
No, it was person. It was actually one person.
From now
it was
on,
one
when you
person.
say people, this is an easy trick and something I started doing. Say minority.
Minority.
Yeah.
Okay.
Just say
And
minority,
also-
focus on
and
them.
also
And now it takes the power.
same with like when you're like, oh, the comments are coming in hot. Like, it's 3 people.
Okay. Okay.
Yeah.
Okay, people.
The only time where I actually get upset with the minority is the situation of
When
how
it's
we
your
met
peers. Yeah.
when it's your peers, and that's when I get really
But it's
upset.
not your peers.
Well, that
it's
was like
randos.
the post on Ozempic or whatever.
No, because those weren't our
Okay.
peers either.
Some pharmacist and empty. Okay. Well, there was, who, but okay. We're not going to talk about her.
But so as you can tell, it's a very complicated space to exist in.
Yes,
So
yes.
I'm glad we share all these trials and tribulations, even though we're on opposite ends of this collaborative spectrum of clinicians and
But it's
scientists.
collaborative, so
Exactly.
It
More
could
of
be
this.
It could be a circle.
Yes, more of this.
If you have a line and
We're
you
a
bend
Venn
it, then it's a
diagram.
circle. There
Yes.
you go. Yeah, it should be
This is a
Venn
triple
diagram.
Venn diagram.
Yes.
If I was having an aerial view, it would be
go.
more
I like
overlap than
that.
not. Yeah.
Yep.
Love
Well, thank you for coming on.
Thank
Appreciate
you
for
you
having
guys.
so
us.
much for
Keep
having
up the good
us.
work. Don't stop. You're not allowed to. If there's a point where you want to stop, you DM me and say we want to stop.
No, I can't.
And I'll fight you.
Okay.
I can't. I just accepted
She has
this.
a torn labrum. I know her weakness on the right
it's healed
side.
now. I had surgery. It's,
No, I'll break it.
it's still crackling a little bit.
Where can people go to learn more about you?
You can follow us on Instagram, Facebook, Twitter, and LinkedIn at Unbiased SciPod. Our website is www.unbiasedscipod.com. And we have a Substack where you can subscribe. It gives you access to our monthly live Q&As and our private Facebook group. And that is theunbiasedscipod.substack.com.
We have show notes for everything. Everything we say is evidence-based. We give the links to the primary sources that we use. We also have, I said show notes, but we have a database, a searchable database that you'll see on our website where you could actually search by keyword if you have a question about a particular topic.
I love it.
Yes.
For those who wanted to see my response to the RSV controversy, click here. You get to see all the negative comments people wrote about me. And as always, stay happy and healthy. So many of my patients, and honestly myself included, struggle with getting good quality sleep. In fact, I would venture to say below back pain, the number one complaint that I get is about insomnia. So today I have a very special guest, Matthew Walker, PhD, a professor of neurology and psychology at UC Berkeley. He actually runs the Center for Human Sleep Science. On Twitter, his username is Sleep Diplomat. He has a podcast about sleep, but it's actually really exciting because a lot of the facts that he teaches in his books and his podcasts all center around why we sleep. In fact, that's the name of his best-selling book that pointed me to his work and got me really excited for this conversation. We talk about the different types of sleepers that exist, including early birds, night owls, the differences between the two, how society judges one versus the other. He gives legitimate sleep tips that actually work and are backed by science, and we talk about this evolving field of sleep supplementation and sleep biohacking. I think you're really going to enjoy this conversation, and you probably won't fall asleep during it, but you definitely will the night after. That's not a doctor point, that's a silly point. Let's get started. Beep-whoop. What is sleep, and how did we, evolve to sleep?
Sleep, actually, I'll take the second part first because it's fascinating. When you think of sleep from an evolutionary perspective, it is the most idiotic of all human behaviors. Because, when we're asleep, we're not foraging for food, we're not finding a mate, we're not reproducing, we're not caring for our young. And worst of all, we're vulnerable to predation. And so on any one of those grounds, but especially all of them collected together, sleep should have been strongly selected against in the course of evolution. However, what we've realized is that in every species that we've carefully studied to date, sleep is present, even very old, ancient evolutionary species. What this means is that sleep evolved with life itself on this planet and then has fought its way through heroically every step along the evolutionary path. And if that's true, it must mean that sleep serves an absolutely vital function. Indeed, it's once been said that if sleep doesn't serve an incredibly vital set of functions, then it is the biggest mistake the evolutionary process ever made. And, now with, 50 years of really great scientific research, we realize Mother Nature did not make a spectacular blunder in creating this thing called sleep to begin with. In terms of what sleep is, it's a very good question. It's an astute one because most of us, and I would think this if I were not a sleep scientist, when we go to bed, we lose consciousness and we think that our mind is dormant and our body gets some rest. And that's really it. And we wake up in the morning. So surely I can shortchange on some of this. Is it really that important? Well, that simplicity belies an incredible complexity because sleep in human beings is broadly separated into two main types. We have non-rapid eye movement sleep or non-REM sleep, and we have rapid eye movement sleep or REM sleep, also thought of as dream sleep, which is the principal stage when we dream. And non-REM sleep has been further divided into 4 different stages 1 through 4, because we're a creative bunch as a sleep researchers in terms of naming. 1 and 2 non-REM sleep, that's sort of light non-REM sleep. 3 and 4, that's deep non-REM sleep. And your brain goes on this incredible roller coaster ride throughout the night. And so when you might go to bed tonight, you'll go firstly into the light stage of non-REM sleep, then the deeper stages, and then you'll stay there for a while. And after about 50 or 60 minutes, you'll start to rise back up, and then you'll have a short REM sleep period, a dream sleep period. And then back down you go again, down into non-REM and up into REM. And that cycle of non-REM to REM plays out in about 90 minutes, at least in us human beings. It's different for different species. But what changes is the ratio of non-REM to REM within those 90-minute cycles as you move across the night. And what I mean is that in the first half of the night, the majority of those 90-minute cycles are comprised of lots of deep non-REM sleep and very little dream sleep. But as you push through to the second half of the night, now that balance shifts over and you have much more rapid eye movement, much more dream sleep, REM sleep, and very little deep sleep. And the reason I bring that up is because many of us will feel, the pressure of modernity, and modernity is desperately designed against sleep in lots of different ways, both through its stigmatization of sleep as lazy and also work schedules. But what that means is that most of us, if we're going to cut our sleep short, it's in those early morning hours. We're waking up early to get a jump start on the day. So you may be losing, let's say, 10 or 20% of your total sleep by doing that. But because REM sleep comes in the last few hours of the night, you may be losing 40, 50, 60% of all of your dream sleep. And as we'll probably discuss, dream sleep is critical for things like learning memory, your emotional health. REM sleep is the time when we all, both men and women, release our peak levels of testosterone. It's critical for our, what we call endocrine health, or our hormonal health. So I just want to paint the picture of both the beauty and the complexity of sleep. And then finally note, by the way, that there is no one stage of sleep that's more important. Lots of people will say, how do I get more deep sleep, or how do I get more dream sleep? And I can understand that natural urge. It turns out that what we've learned is different stages of sleep perform different functions for your brain and for your body at different times of night. They're all necessary. Otherwise, Mother Nature would have removed anything that was unnecessary long ago.
Do you see outliers in people who experience these stages of sleep differently, either with shorter intervals, one versus the other, or perhaps not being accustomed to the 90-minute typical interval of the entire stage?
Oh, it's such a great question. You need to be a sleep researcher or do a sabbatical for a year. It's a great question, which is about what we call the variability. So you and I will probably be discussing the typical averages for the average adult. But around that sweet spot of the average, there's a huge amount of variability when it comes to sleep. The first is in terms of sleep need. And, people like myself have probably been on record saying, you need, this on average 8-hour sweet spot. And it seems to be on average about that. But the recommended range is somewhere between 7 to 9 hours of sleep. That's 2 hours of variability. Some people can function perfectly well on 7 hours and 15 minutes. Others can't. They need at least 9 hours to function well. So there's variability in terms of total time of sleep. There's also variability in terms of the different stages of sleep. We know that genetically, there is some predilection to you being a more powerful deep sleeper. So you'll have the reason that we call it deep sleep in part is because the electrical brain waves, as you go into deep non-REM sleep, stages 3 and 4, all of a sudden you get these huge, big, powerful, deep, slow brain waves. And depending on your genetic composition and what you've been doing during the day, and also your age, the size of those deep, slow brain waves is different. So there's variability there too. There's variability in how much REM sleep that people will get. So it's a very good point. And then the final aspect is there is variability in that 90-minute cycle. That's the average. Some people will have a sleep cycle consistently of maybe just 75 minutes. Others all the way up to, let's say, 105 minutes. So there is variability in that cycle. I know that some people would hear that and then they've tried to architect their sleep so that they wake up with this metronome-like quality to say, okay, so when I fall asleep, then if I pattern out those 90-minute cycles at 7:35 in the morning, that's the time when I'm ending my last cycle. I should wake. It's not like that at all. There's variability.
Yeah, like that biohacking hyper-optimization is very tough to achieve, if not impossible, in not just sleep, I would say in the majority of sciences. Whether you're talking about nutrition, diet, mental health, there's no such thing as perfect anything, really. Because anytime you strive for perfect, you create a whole set of other problems you probably didn't expect. Would you say that's right? The same for sleep, about biohacking sleep? Yeah,
very much so. And I really embrace what you're saying there about just biohacking in general. For me, biohacking, I think it's interesting, and I think it's good for us to explore with technology, pharmacology. What aspects can we bend in terms of some of the rules? I doubt that there's anything that we can break in terms of the rules. But what I also realized too is that it's probably hubris for us to think that within the short term of a lifespan that we could create something better in terms of a sleep need and a sleep schedule than something that Mother Nature took, more than 3.6 million years to evolve. And when you fight your biology, let's say that you're trying to optimize your sleep in these ultra short cycles. It's sometimes called the Uberman cycle, where you're sort of going in these 45-minute stretches, then you're awake for 90, or lots of variants of that. Mm-hmm. What we found is the evidence there is very clear. That type of sleeping is associated with poor mental health outcomes and poor physical health outcomes. So, sleeping like a baby when you're an adult is a bad idea. And that's what the Uberman schedule in some ways is. But overall, I think when you fight biology and the natural tendencies of how we've been designed, which you could argue biohacking is a little bit of, you normally lose. And the way you've lost is disease, sickness, and ill health. So I try to stay away from it as much as possible for myself.
We need to put that as personally. A banner for the Silicon Valley folks that consistently pitch their products.
Yeah, well, living, here, in Berkeley and not too far, and I have many different feet in those different worlds of technology with sleep, of course. So it's something I work on a lot and I think about a lot, and work with companies and have some startups of my own that are trying to think about those ways, but always with this deep reverence, this incredible respect for the process of how we've evolved, and not wanting to move forward with that arrogance.
Absolutely. That's such a smart approach to it. Actually, refreshing to hear, because a lot of times when you have experts in a given subject, they're quick to want to change everything or find that shortcut. So it's nice to not to see the approach from the other side of the spectrum. We talked about the differences in the deep sleep, the REM sleep, the intervals. Is there also differences by individuals who prefer morning, night, and then maybe as well in terms of not just the hours of sleep, but the time of the day in which you sleep?
Yes, there is. And that's a really important second feature of sleep, which is that it's not just about the quantity of sleep that you get in terms of hours. And also another important feature is quality of sleep, which we can come back to. But one thing that many of us forget is the timing of our sleep. And this comes back to a concept biologically well defined called your chronotype. So are you a morning type, evening type, or somewhere in between? And depending on the data, it's about a third split across the population. I should probably note that before I move any further, lest anyone think that I'm biased in what I'm about to say, I am unfortunately just like the rest of my pedantry in terms of personality. I'm desperately boring. I am completely vanilla. I'm a neutral. I'm sort of like an 11 to 7 kind of guy. But your chronotype as to when you want to go to bed and wake up, it's not your fault and it's not your choice. Because it turns out that it's genetically determined. And we now know that there are at least 9 different genes that will dictate your morningness versus eveningness preference in terms of being a sleeper. What we call, are you a night owl or are you a morning lark? And it's gifted to you at birth. It's hardwired and it's very difficult to change. And the reason this is important from a practical perspective for people to know, and by the way, if you want to know truly what type you are, you can go online and you can search for something called the MEQ, or you can type it out, which stands for the Morningness Eveningness Questionnaire for Chronotype. And it takes about 3 or 4 minutes, really easy, and you get your type. You can also do it in a quick fashion. You can just say, look, if you or I were on a desert island, nothing to wake up for, we could go to bed whenever we really wanted to and whenever we really desired to wake up, rather than when society forces us to go to bed and wake up. What time would that be? And for most people, that time as to when they would like to go to bed and like to wake up is very different than what time they actually are currently trying to go to bed and trying to wake up, which suggests that modernity has inserted a wedge of a mismatch in terms of our sleep timing based on our chronotype. Because society is desperately geared towards and biased towards morning types. It's this, the early bird catches the worm. Those are the people that are praised. That leaves out in the cold and chastised, wrongly so, as if it's their choice, the evening types. And the early bird may catch the worm, but I would also say that the second mouse gets the cheese. And so, there's lots of ways that we should be much more kind to ourselves and others in society regarding evening types. The practical part of it comes to people that I'll see at my sleep center here who will say, look, I just have terrible insomnia. I have difficulty falling asleep. I go to bed and I'm just wide awake for the first hour. I just cannot fall asleep. And then I'll ask them a little bit more about their chronotype. And it turns out that there's someone who at the weekend, finally, they would normally be going to bed about midnight, 1 a.m. But during the week, because of their schedule, of course, and understandably so, they're forcing themselves to get into bed at 10 p.m., which is a 2 to 3 hour difference relative to your natural chronotype. So no wonder your biology is not even yet ready to try and help you fall asleep. But you're sitting there in bed just wishing it to happen. And you can't wish for sleep to happen and make it. It's not like a light switch in that sense. And so it masquerades almost like what we call a form of sleep onset insomnia. There's also something called sleep maintenance insomnia. So do you have difficulties falling asleep or difficulties staying asleep? And they're not mutually exclusive, by the way. But people with a chronotype who are a night owl, they can sometimes have that challenge. They're in bed too early and they can't fall asleep.
That's probably one of the most important points to discuss today, because as a primary care physician, obviously insomnia, whether it's the start of sleep or disrupted sleep, not being able to fall asleep afterwards upon waking in the middle of the night, it's easy for me as a physician to either look just to lifestyle changes, talk about sleep hygiene, discuss caffeine usage, alcohol usage, things that would impact sleep from my training level. And maybe even mental health. Like that would be a step further that I go that most physicians probably don't even get to in their 15-minute visits, unfortunately, in our current healthcare system. But should we be, as physicians, thinking about chronotype more?
I think we should certainly be asking that as part of the equation and being sensitive to that in terms of understanding it. It turns out that there's a whole field of chronobiology and chronopharmacology, because as we've now started to understand, drugs can have different potencies of effect on the basis of different times during the 24-hour cycle. And there may be more or less potent times for you to provide that medication. Sometimes for hypertensive medications, there's some evidence that time of day is important. There's a big field demonstrating that cancer medication can have a chronotype dependency, non-trivial in terms of its efficacy. So I think that's important. I also, I love the way that you think about not just going to sleep hygiene, which is critical, and being mindful of alcohol, which is no friend of sleep, and caffeine equally so. And then moving to mental health, because what we know is that perhaps one of the biggest common central pathways through which your body instigates this thing called insomnia is having an overactive fight or flight stress system within the body, which is part of your the automatic nervous system. It's called the sympathetic nervous system. It's anything but sympathetic. It's very agitating, aggravating. It's the fight or flight branch, together with something called the HPA axis, which is part of your hormonal axis, particularly regarding a hormone called cortisol, which is a stress-related hormone. And when those things are switched on, which sort of high levels of anxiety, worry, and stress will very much do, sleep is almost impossible. And it results in people, the phenomenon that I would describe as tired but wired, where they are so desperately tired, but they're just so, from a mental health perspective, to your point, they're just so wired that they can't fall asleep. And until you actually target the treatment of the mental health component, it's going to be very difficult to, one could just simply offer, sedative sleep agents to try and knock the cortex out. But we know that there are increasingly better ways. And I think one of the things that physicians have maybe started doing is becoming aware of the current recommended alternative to sleeping pills, which is something called cognitive behavioral therapy for insomnia, or CBTI for short. And I would say that for any for any general physician, any GP who is facing a patient who is saying that they are struggling with sleep, trying to at first direct them towards cognitive behavioral therapy for insomnia and trying to find a provider for that. I know it's difficult. It turns out if you look at the number of people who can provide it, there is a mismatch between demand and supply. There's not enough supply for the demand. Nevertheless, being aware of cognitive behavioral therapy for insomnia is critical. There are now some apps that you can use as well to help with that, to make it more convenient. That's the only thing I would add to that equation.
Yeah, absolutely. I'm a big proponent of CBT. I even have been able to institute some introductory, I wouldn't say they're introductory sessions, but maybe basic understandings that I can pass along to my patients until they're able to see a mental health provider about what CBT is, how it works, where we work on thoughts as opposed to feelings. Because in reality, the mind-body connection is so much connected that we give it credit for, that patients oftentimes are ready to get a physical diagnosis and are really surprised or even shocked when everything comes up normal, the imaging, the lab tests, and it's only until we get to their mental health do we figure out that's where the problem is at least beginning and then showing itself. So sleep is definitely one of those.
That's so powerful, to think that, a physician in this day and age, and I know I'm not pointing any fingers, the job that you have is so immensely difficult within these compressed zip file time periods. Mm-hmm. You're supposed to go through this complex biological organism in front of you, quickly make a diagnosis, understand the treatment path outcome, prescribe, and get so that someone like you is being already able to think about cognitive behavioral therapy and then give the stepping stone components to help them on their journey as they start to seek out that further. How much better would the world be, if that was more common practice? I can't imagine.
I think it would improve health outcomes significantly. That's why I'm a big proponent of increasing funding for primary care, because the struggle that a lot of physicians have is those 15-minute visits with patients that are unknown to them, that they don't have a history with, like the urgent care model, where a patient comes in to see a doctor they've never seen before, and somehow in 15 minutes, this physician's supposed to create a rapport with this patient, learn about their condition, their symptoms, potentially connect it to some sort of cause, create the treatment, make sure that the patient understands the treatment, that they can afford the treatment, they have access to the treatment, and then document that entire interaction in 15 minutes. On what planet? And then make sure the insurance approves that treatment.
Right. Yeah. What are we doing if our goal is to try to care for other human beings in the most medically sound way possible? So you are, heroes to keep doing that, and thank you for what you do.
Thank you. I appreciate you saying that. For the patients that are struggling with falling asleep, that potentially could be a different chronotype. Is there something I should be recommending to those patients about changing maybe their job, maybe the times at which they sleep? Is that as far as I should be going with this, or should I be looking for a pharmaceutical approach for those patients? What's your recommendation there?
Usually, and again, I'm not a medical doctor, I'm not an MD, but I think that certainly the idea of moving to medication for that situation could be a few steps further down the path before the earlier low-hanging fruit are accomplished. One would be to see, how can we try to just move your schedule even just a little bit? And now post-pandemic, schedules are never more flexible. People have incredible control, or much more astute control over their own schedule. And so trying to see if you can prioritize that as best you can would be ideal, so that you yourself sleep in harmony with your chronotype rather than mismatched or out of sync with your chronotype. So I think having people become aware of it, firstly, most people aren't even aware that there is this thing, chronotype and how it impacts. And second, once they become aware of it, this is real and you can do something about it, and you will start to sleep better as a consequence. I think then also there are ways, although people have tried to make evening types more like morning types, and it's very difficult because it's genetically based, but you can help yourself. You can start to really try to limit your caffeine in the second half of the day and nix it in the evening. Try to stay away from alcohol in the evening. Again, I don't want to be puritanical. I'm not here to tell anyone how to live their life, and life is to be lived, but just keeping that in mind. The other thing is to try to really reduce down the light exposure. So if you are a night owl and you're being forced to go to bed earlier than you would otherwise, start to already tell your brain that it's nighttime, because we are a dark deprived society in this modern era. And we need darkness at night to release a hormone called melatonin, which helps with the regulation of our sleep timing. And that's why for evening types, it's so important. And so the recommendation, in fact, for everyone, but particularly night owls trying to go to bed earlier, would be in the last hour before bed, shut down almost all of the lights in your house. And of course, staying away from screens, but that's not enough. And what you will find is that reduction of light at night will be surprisingly soporific. It will help you feel more sleepy and more tired, because most of us are in this blaze of electrical light at night. Then we shut it all off, we dive into bed, and we hope for sleep. And that's also not going to happen in terms of a transition. So darkness at night is great. Then eye mask, earplugs, blackout curtains, and finally get your room cold, because your brain and your body need to drop their core temperature by about 1 degree Celsius, or about 2 to 3 degrees Fahrenheit, for you to fall asleep and then stay asleep. And if you look at chronotypes, people who are particularly night owls, their core body temperature drop is not starting to descend until those early morning hours, until midnight, 1 a.m. But yet they're getting into bed at 10 when their core body temperature is not on its awesome downswing of sleep promotion. So you can help by having a really cool bedroom, somewhere around about 65 degrees, will help in that regard as well. So those are a number of things that you can try to recommend and do, before one starts to move down the path of maybe thinking of pharmacology.
I have two questions. The first being, in moving in these different chronotypes, when we're talking about someone who's a night chronotype versus a morning chronotype, how much of a difference of recommended time to go to sleep are we talking about? Are we saying those people would prefer going to bed at 6 a.m., or is it a 2-hour difference from like an 11 p.m. to a 1 a.m., as you said?
It's actually a gradation. And so although I sort of mentioned these 3 buckets, sleep science has now gone even further and thin sliced it into 5 buckets. So you can be an extreme morning type, a neutral, an evening type, or an extreme evening type. So extreme morning types could be getting into bed around 8 p.m., which is, quite remarkable in some ways. Whereas extreme evening types may not want to go to bed or even be ready to fall asleep until 3 a.m., maybe even 4 a.m. in the morning. So that is a vast difference. And then across those sort of more fine grained separations, the difference then will start to get closer and closer and less extreme as a consequence. But the distance between those two can be whopping. And can sometimes be a problem. If we'll see this too in couples who have very different chronotypes. It can be a very challenging situation because one of them is getting into bed, at 9 p.m. in the evening, and then the other is getting into bed 3 hours later, just as that other person is now 3 hours into their nice deep sleep cycles, and they're getting disrupted. And then come the morning, now the early bird, they're awake at, let's say, 4 or 5 a.m. in the morning, and the evening type is now in their first ending half of the deep sleep sort of cycle, and then they get woken up. And so there can be a real challenge based on when that mismatch is very, very different. But I would say it's more of a gradation in some ways, rather than just sort of definitely categorically you are 2 hours different than sort of this person. Does that make some sense, Mike?
No, absolutely. It's a spectrum of sleep, if you will.
Yeah.
The concern I'm already having in my head, having conversations about chronotypes with my patients, is that they're going to be quick to label themselves a specific type of sleeper and remove the recommendations about sleep hygiene or whatever they potentially could be doing wrong, or what could be going on in their mental health, and assume that it's because they're just not this type, and it becomes a self-fulfilling prophecy. Is there any way that in the research that this was controlled for, that these people weren't just the ones living unhealthier lives or having higher levels of anxiety outside of their control, and they happen to be late sleepers? Or is this definite genetic tie here?
Yeah, it's a definite genetic tie, and you can see it in animal studies. You can manipulate those genes, and you can force causally animals to become, a different sort of what we call circadian 24-hour rhythm. So it's definitely causal in terms of manipulation. I do think that and by the way, when you look at those studies for, let's say, evening types who are not sleeping as well as they could be, it is related to a significant number of marked worse health outcomes. High risk evening types will have a high risk of diabetes, markedly high risk of depression, high risk of cardiovascular disease, high risk of being having a higher BMI or being obese. There are a number of associations here, and you can control for those things by inserting, lifestyle, age, smoking history, exercise history, and those associations still typically hold out. And I would say that the sleep hygiene recommendations that you provide and many of the sleep suggestions that we've had regarding optimizing and bettering your sleep are applicable no matter whether you're a morning type or an evening type. They are efficacious in both types. So it really is important for you to be able to sort of modulate your sleep habits and your sleep beliefs. In other words, what we call sleep hygiene, if you want to try and get the very best out of your sleep, no matter whether you're an evening type or a morning type. If you are an evening type, do be aware of it. Try to think about it, be cognizant, try to modulate a schedule, but also don't ignore those other things. Please don't feel that you need to be fatalistic about it to say, well, I'm just an evening type and that's me and I'm doomed in terms of my sleep. You are absolutely not doomed. There's lots of things that you can do.
Interesting. I wonder, maybe you can point me if a study like this exists. We know in our literature that those who work night shifts and develop either shift work disorder or just happen to work night shifts, they have worse health outcomes long term. Now, I wonder if that holds true for those who are a very extreme late night chronotype. Would you still see those negative outcomes? Has that been studied?
It has been a little bit, and it does seem to be that there is some degree of lowered in. Now, it depends on the night shift work because, if it's 100% out, what we call out of phase, where you're working at night and you're trying to sleep during the day, then even if you're an extreme morning type or an extreme evening type on either side of that spectrum, your sleep is going to be much more of a struggle during the day. because we are a nocturnal species. We're a diurnal species, so we're designed to be sleeping during that sort of nocturne phase, that night phase. So no matter what, that's going to be a struggle. But let's say that you're working, the early phase of the morning into the sort of early afternoon. So you're having to wake up at 2 a.m. in the morning or 3 a.m. That is much easier if you are an extreme morning type, because you're much closer to your typical, what we call sleep offset. In other words, your wake up time. Whereas if you are an extreme night owl and you're working that shift, then that's much more difficult. But if you are required to work from the sort of mid-evening until the early morning hours, now the opposite is true. That favors the night owl, because they don't mind staying awake until 2, 3 in the morning. Whereas for a morning type who likes to go to bed at 9 p.m., staying awake until 2 or 3 is not the same thing. It's sort of, it's like asking an evening type to then stay awake all the way through until 9, 10 a.m. in the morning. Even that's too extreme for them. So there is an accommodation that can happen based on chronotype. And it's sometimes been suggested that, now you can't do this legally or ethically, of course, but should we not be asking people about their chronotype and seeing if we can better match them to jobs that would fit their chronotype more? Now, that's me being a sleep, perfectionist, and in an ideal world, that would be the case. But, I think there's some reasonable cause for something like that.
Would it be reasonable to change the way we think of shifts? Maybe instead of a night shift and a day shift, we have like a middle of the night shift, late day shift, instead of, from midnight to midday, you have from 3 a.m. to 3 p.m. Would that be more effective for most people then?
It's a very good question, which is how should we better structure, shift work on the basis of now what we know in terms of the deleterious outcomes. And people have studied this, and they've studied it very well, and they've studied it in depth. And I think what the evidence really points towards is that, firstly, you shouldn't flip-flop between extreme schedules very quickly. So you shouldn't do, 3 days of night shifts and then have 1 day off and then switch to 4 days of daytime shifts and then switch back to 3 nights of night, which is residency, which is... that's shockingly bad. That's torture for your biology. Instead, the idea is, firstly, you should do longer stretches of one thing, then take a break, then longer stretches of the other, and then sort of go back and forth in a much more glacial pace. Mm-hmm. The other idea, which I think is even more nuanced and clever, is rather than doing these blocks where you're either doing the day shift or you're either doing the night shift, instead, you just rotate people around the 24-hour clock face. So now, you start by doing the afternoon and evening shift, and you do that for a while. Then you go on to the evening into early morning shift, into middle of the night shift, I guess would be the case. And then you shift over to from the middle of the night into the mid-morning hours, and then you just kind of keep cycling like that. That seems to be a way that you can perhaps be better adjusted or better acclimated, even though ultimately you just can't. There's no way that a human being within the space of 60 years of working shifts, they're not going to accommodate, because once again, it's been millions of years of biology in terms of evolution that have designed our circadian rhythm, and it's very hardwired and it's very innate.
Yeah, I'm curious about that.
You can't just overcome it like that.
Because if you have the circadian rhythm, which is like, I guess my knowledge of what a chronotype is would be based on a circadian pattern. How did this wedge come to exist? Is there an evolutionary benefit to this wedge of chronotypes? Or is this an error on Mother Nature's part?
We don't think it's an error. And I think... I've written about this before, and other people have spoken about it before. I think it could be a very elegant design of Mother Nature to outsource the threat that we face when we are unconscious for 8 hours. What I mean by this is we as human beings, if you look into our history, we were typically not solo sleepers or coupled sleepers. We were actually group sleepers. So we would typically sleep in groups as a tribe. And so if you think about this now, each one of those individuals in the tribe is going to be vulnerable at night for 8 hour stretch, if we just assume 8 hours. However, as a group, as a collective, if there are some people who are going to bed, 4 or let's say, 3 hours earlier, and then there are other people who are going to bed 3 hours later, then you've just taken that 8 hour vulnerability window. And now as a collective, there are going to be people who will be awake for the first 3 hours still, the night owls, and then people who are going to be waking up earlier, who will be awake for the last 3 hours of the sleep phase. So now you've got, as a group collective, the first 3 hours of sleep and the last 3 hours of sleep covered. And so you as a group, as a collective, perhaps are only all sleeping at the same time for maybe just 2 hours of the night. So Mother Nature compressed the time threat period from 8 hours all the way down to 2 hours by creating this thing that we call chronotype variability.
Wow, that's so interesting. Who knew nature was like a natural hospital staffer to make sure that there was always someone to care for patients?
Absolutely. Mother Nature in terms of an administrative role of scheduling is absolute perfection.
Yeah. It's a shame that life is so complicated and complex and so many things change that it can never be as perfect as designed. But wow, sleep is obviously very exciting. Well, talking about getting the adequate numbers of sleep, what happens when we don't? In your book, you talk about Alzheimer's, we talk about physical health outcomes. Can you shed some light on that?
Yeah, I think 50 or 60 years ago, we used to ask the question, why do we sleep? And back then, perhaps the unhelpful answer was that we sleep to cure sleepiness, which is the nonsensical equivalent of saying, well, you eat to cure hunger. That tells you nothing about the nutritional benefits of food. But now, after 50, 60 years of remarkable research from all of my colleagues, we've had to upend the question. And instead, we've had to ask, is there any operation of your mind? And is there any major physiological system within your body that isn't wonderfully enhanced when you get sleep or demonstrably impaired when you don't get enough? And the answer seems to be no. We know that the number of people who, let's say, could survive on less than 6 hours of sleep a night without showing any brain or body impairment, rounded to a whole number and expressed as a percent of the population, is 0. Yeah. And so what that tells us is that sleep is non-negotiable. It's unfortunately not an optional lifestyle luxury. It's essential. And when you look at the deleterious health outcomes, firstly, you could look at hormonal health. And we know that men who are put on a limited amount of sleep, let's say 4 or 5 hours a night for a week, they have a level of testosterone, which is that of someone 10 years their senior. So a lack of sleep will age a man by a decade within just a week in terms of hormonal health. You see equivalent impairments in females in terms of luteinizing hormone, estrogen, follicle stimulating hormone. Or we can look at what we call the metabolic system. And what we've discovered is that, again, after 1 week of short sleep, let's say 5 hours a night, each night, your blood sugar levels are so disrupted that someone like you, the GP, after doing a blood test, would actually classify them as being pre-diabetic. And that happens with what we call people who are normative in terms of the glucose profile. But after 1 week of bad sleep, they are on the path towards diabetes. There's another, I think, example I'll often give, which is a more extreme one, but yet a more subtle one, which is the global experiment that is performed on many of us. In fact, about 1.6 billion of us across 75 countries, and it's done twice a year. And it's called daylight savings time. And there was one amazing research report that demonstrated that in the spring, when we lose just 1 hour of sleep, there was a 24% increase in heart attacks, the relative risk the next day. But yet in the fall, in the autumn, when we gain an hour of sleep, there was a 21% reduction in heart attacks. So it was bidirectional. And we've now found a very similar pattern during those transition periods for things like road traffic accidents on our streets, even suicide rates, in fact. So I think these are examples. There's another great study that was looking at the immune system. And what they found was that one night of just 4 hours of sleep dropped critical anti-cancer fighting immune cells that we call natural killer cells. It dropped them by up to 70%, which is quite a quick state of immune deficiency after a poor night of sleep. Now, I offer these scientific pieces of evidence, to support the case that it's critical for health. But I also know that in doing that, for those people who are struggling with sleep, how do you balance that tension as a public communicator? Because now I don't want to get people even more stressed about the sleep that they're not getting. So please, if you're struggling with sleep, firstly, turn my voice off. Stop listening. I'm sorry about the views and the clicks. But the second thing is, look, everyone has a bad night of sleep. Even I do. And I've had my bouts of insomnia throughout my life as well. A bad night of sleep, it's okay. It happens to all of us. Don't worry. Don't freak out. Don't get too anxious. But if you are persistently struggling with sleep, go to see your doctor. Ask about help for insomnia, and particularly cognitive behavioral therapy for insomnia. But I just want to put that out there. I don't mean to be triggering. I don't mean to be alarmist. I want to build the case, the evidence-based case for sleep, without necessarily, making people too worried.
I think that's such an important point to make, because what's interesting about having not enough sleep is it harms your mental health. And then if you have issues with mental health, that harms your sleep. So you're kind of in this cycle where if we're constantly talking about not getting enough sleep and how dangerous it is, it can actually hurt your ability to sleep, right?
That's exactly the irony, which is that, and we've seen this, we've done a lot of work on sleep and mental health over the years. I think one of the striking findings there that we found was that in the past 20 years, we have not been able to discover a single psychiatric condition in which sleep is normal. And I think that tells us everything that we need to know about the relationship, the intimate relationship between our sleep health and our mental health, our emotional health. And it is bidirectional. What we've discovered is that and we published a study a few years ago demonstrating that if you took perfectly healthy people who have no signs of an anxiety disorder whatsoever, and you deprive them of sleep for just one night, almost 50% of them the next day classify as having an anxiety disorder because their anxiety is just skyrocketed. And we found out why, because there are emotional changes within the brain. These deep emotional anxiety centers were just erupting in terms of their sensitivity and their reactivity. So insufficient sleep can lead to anxiety, and there's causal evidence for that now. But also, having anxiety can then consequentially lead to worse sleep. So, poor sleep equals, poor mental health, but separately, poor mental health can equal poor sleep at night. And when those two things begin, almost like two bad kids conspiring together, it becomes this vicious cycle of a self-fulfilling prophecy of worse insomnia, worse sleep difficulties, and if that's the case, increasingly worse depression or anxiety, which then just escalates the problem. Highlighting the importance of the CBTI that we can offer our patients. Correct. Before I ask my last question, this is more of a curiosity that I've had, and I've sort of blamed it on the sympathetic nervous system driving us when we don't get enough sleep, so you can feel awake. But then when you
I guess let me ask the question and I'll sort of give you my theory and you tell me how wrong I am. Why when my patients, and I guess I've experienced this for myself as well, when if you're going through a period of not getting enough sleep, sleeping 5 hours a night, and then you have a night where you do sleep 7-8 hours or the correct amount of sleep for you, you feel more tired the next day than if you were to sleep to 5-6 hours.
Isn't it fascinating? And although it's been less well documented in the science, it's so common in terms of anecdote that I think it's very clear. It's sort of when you look, at Amazon user reviews and you see, 30,000 people have given it a 4.9 rating. You kind of got to think that it's probably a good product. Well, when you get that number of people in the general public saying this is happening, you've got to believe there's something to it. What we think is happening here is that each night after night, when you're not sleeping well, you're building up what's called a sleep debt. And your body understands its sleep debt. Now, in part, sleep is not like the bank. You can't accumulate a debt and then hope to pay it off without consequence. However, the body and the brain will try to get back some of the sleep that it's lost. So let's do the extreme example. I take you tonight and I deprive you of sleep for 8 hours. And then I give you all of the recovery sleep that you want on the next night and the next night and even the next night. Will you sleep longer those subsequent nights? Absolutely. You'll have what's called a sleep rebound. But will you get back all of the 8 hours of sleep that you've lost? Not even close. You may only get back 50% of that lost sleep. In other words, you can make up some of that debt, but you can never repay all of it. But what's interesting is that as you're repaying it, because you've built up such a strong debt, such a heavy weight of sleepiness and sleep pressure after 2 or 3 bad nights of sleep, then you sleep deeply. You have that sleep rebound effect. And because you've gone so deep into sleep, the next morning when you wake up, you have something called sleep inertia, almost like sleep drunkenness. And as you describe, you almost feel worse as a consequence. Now, that is just the process of your brain and your body telling you, firstly, excellent, you had a great night of recovery sleep. But second, we're not done yet because you still need some more nights to wash out some of that lingering debt. And the grogginess and the sleepiness that you're feeling is still a reflection that you cleared some of that, but by no means all of it. And your brain, in fact, was still hungry for more and still wanted more. You're just going to have to wait a few more nights before you get that back. But because we all naturally think, okay, it was that one night, but why am I still groggy? Why am I still sleepy the next day? We never think of sleep as having this sort of, day after day, night after night timeline to it. We think, I had a few bad nights of sleep. I should be able to do it all in one recovery night and wake up feeling like the Energizer Bunny. It takes more time than that. Does that make some sense?
It does. It doesn't answer my question, though, why if I was to sleep 5 hours and not replenish my sleep, I wouldn't feel as tired. Is it because that I didn't go into that deeper sleep?
So there are 2 possible reasons. The first is that you still will have gone into that deep sleep, very much so, but you won't have had as much sleep. So you won't have had as much sort of inertia, momentous to have that effect the next morning. The other issue is that, yes, when you are brute forcing yourself awake and you're not sleeping the amount that you need, the nervous system will start to kick into higher gear. And in some ways, it's a threat detection system because human beings are the only species that will deliberately deprive themselves of sleep for no good reason. And when you see other species doing this, it's usually under conditions of very high threat from predators or under conditions of starvation. And at that point, the brain and the body switch on the hyperdrive of the sympathetic nervous system to try and help keep you awake, because you are telling your brain by not sleeping enough, well, there must be a threat, because the only time during evolution when I've not been sleeping enough is when I've been under attack. So no wonder I get wired and I feel pretty alert. The second problem there, however, is that we say that we feel more alert. We say that we're operating and performing better. But your subjective sense of how well you're doing when you haven't got enough sleep is a miserable predictor of objectively how well you're doing with insufficient sleep. So this is kind of like this, machismo attitude. I'm doing fine. But in truth, it's a little bit like a drunk driver at a bar. They've had 5 or 6 shots. They pick up the car keys and they say, look, I think I'm fine to drive home. And your response is, I know that subjectively you think you're fine. Objectively, you're impaired. Don't worry. Let me take the car keys. I'll call you a taxi. It'll be fine. The same is true with sleep. We don't know we're sleep deprived when we're sleep deprived in terms of impaired performance.
Yeah. That's sort of the line I was thinking when I was saying it's the sympathetic response that makes you feel like you're awake. When in reality, your reaction time suffers, creativity, productivity, all of that. My last question before we wrap up here is about sleep supplements, sleep treatments, medications. For me, just to give you my bias, is I'm kind of against supplementing unless there's an absolute proven need to do so. And yet there's a market for a miracle cure-all product for everything these days. We try and push against that on this channel. For sleep, my patients will turn to CBD. Melatonin has cases where it works quite well for jet lag, sleep cycle issues, but in general, what are your thoughts on some of these over-counter medications, whether it's the chamomile teas, the melatonins, the CBD supplements, all those?
Yeah, I think that if there was this one incredible compound or set of supplement compounds that was the holy grail for good sleep, that was the Shangri-La of all sleep, concoctions, then trust me, the drug companies would have discovered it 20 or 30 years ago, and it would now be a pharmaceutical that they're making billions from. And there is no such thing. So if you're seeing the promise of the best night's sleep by taking this supplement, chances are you're going to be disappointed. The evidence is very mixed for most everything that you described. We know that melatonin, you're absolutely right, can be effective when you're traveling between different time zones. But once you're stable in a new time zone, melatonin is not the solution for most people's sleep problems. In fact, there was a meta-analysis, which is a technique where we take all of the individual studies and we put them together and sum them all up. And what they found is that melatonin, I think, if I'm remembering my numbers correctly, only increased total amount of sleep by, it only increased the speed with which you fall asleep by about 3.9 minutes, which relative to placebo, and then it only increased your sleep efficiency by 2.2%, which again, isn't much. Now, some people have said, and I understand it, that if you feel as though it's working for you, the placebo effect is one of the most reliable effects in all of pharmacology, short of probably an adrenaline injection to the heart. So, no harm, no foul. The only thing with melatonin, I would say, is that because it's not regulated, you don't know what you're getting. And there's a study that looked at lots of different brands. And what they found was that relative to what it said was on the label, actually what was inside of each tablet ranged from being 80% less than what it said to 460% more than what it said. And so you don't know what you're getting. We also know a recent report from my dear friend, a wonderful pediatric sleep specialist, Craig Canapari. If anyone is a young parent out there and you need sleep advice, go to Craig Canapari at Yale. He is a genius. And he was just alerting people to the fact of a recent report showing that I think there was a 500% increase in the reported overdosing of children with melatonin. Because you can go down to the supermarket aisle these days.
Yeah, the dosages are incredible in the supplements.
That's the thing, and that's a great point, actually, Mike. When it comes to melatonin and many of these other supplements, you're taking what we would typically describe as a supraphysiological dose, a dose that is far larger than anything that your body would create or see or produce. And one of the worries when you have supraphysiological doses, and testosterone supplementation is an example here, that once you start giving the body an outsourced version of that, it has a feedback loop, and it can shut down or at least decrease its own production. And so by taking too much melatonin, and most people do, they'll take maybe 5 milligrams or 10 milligrams. The optimal dose seems to be somewhere between about 0.8 and 3 milligrams, much less than what most people are taking. So keep that in mind. You want to just be very judicious, but also know that it doesn't seem to be that effective. Things like magnesium don't seem to be very effective. If you look at the literature, most magnesium compounds you buy out there don't even cross into your brain. They don't cross something called the blood-brain barrier. Magnesium threonate, or MAG-T as it's known, that may be the one exception, and there's no good sleep data on that yet. Things like valerian root, debatable. Chamomile tea, not really. There is some evidence that I think is interesting in two areas. One is glycine, and there has been some good studies demonstrating from very good laboratories that some degree of consistent benefit of glycine, anywhere, I think, from about 1 gram up to about 3 grams. But again, Wild West, you don't know what you're getting in the market space, and it's no cure-all for insomnia or sleep difficulty. And then the other is tart cherry juice and kiwis. And I was looking at this evidence thinking, this is nonsense, absolute nonsense. But again, the people who were doing the study is very respectable. And the evidence was there in some animal studies and also in some human studies. Now, there are far too few studies for any of us to recommend people doing that. But let's just take it that it could. How could it do that? Both of those things are packed full of something that we call antioxidants. And there's been a revelation in the past 4 years in the sleep field that antioxidants play a huge and powerful role in regulating our sleep and even protecting us against the ravages of insufficient sleep. So I think that's an interesting space. The final thing I would note is THC and CBD. And I get asked this question quite a lot too, and I'm sure you do too. THC, or tetrahydrocannabinol, is the psychoactive component of cannabis. That's the part that gets you high. That may help them fall asleep quicker or lose consciousness more quickly, but it is no friend of sleep. Firstly, you become tolerant, and you become tolerant quite quickly, and you start to have to take more to get the same sleep benefit. Worse, when you stop, you get a vicious sleep rebound, an insomnia syndrome. In fact, it's part of the cannabis withdrawal syndrome in the diagnostic manuals because it's so reliable. So the other aspect of THC is it can decrease or even block the amount of REM sleep, dream sleep that you have. And we've discussed that that's critical. In fact, many heavy cannabis users will say to me, I just stopped dreaming, and I really don't remember my dreams anymore, because you're not having much of that dream sleep. And then when they stop, they'll say, I'm having these incredible vivid dreams. It's so surreal. It's because your brain is trying to recover some of that REM sleep that it's been deprived of for so long. CBD, not enough evidence, but it's interesting. And I'm very careful as to what I say here, because, when you have people like me and people say, okay, he seems to know a bit about sleep, then if he said something, then it must be, right or scientific proof. We don't have anywhere near enough evidence on CBD to make any recommendations for sleep. There is some evidence in animal studies in rats and some evidence in humans that in higher doses, and I think those doses may have been, above 25 milligrams, maybe more, it can be more sleep inducing. But one of the dangers is that at lower doses, it seemed to actually be wake promoting. So it has this bimodal distribution. And again, you don't know what you're getting. Are you getting CBD but too little? And it's going to cause you even worse sleep because you're going to be more awake. Or is it going to be enough that it, helps you with sleep? Help, because I say in inverted commas, because we don't know if it helps. I think there are companies, and for a long time, I realized the ill of my ways. As a scientist, I would get very, once again, kind of purist about it and say, these are snake oil companies, selling stuff. You stay away from them because there's no good science. Well, there's probably only going to be good science, if scientists themselves stop having that mentality, that exclusionary mentality, and start working with some of these serious companies and help them do the studies. And let's find out together. So I've actually started to work with a company that is really focused on very good medical practices with CBD, and we'll see where it goes. Let's think about a model where in 10 years' time or 5 years' time, we have evidence that CBT is beneficial for sleep. How could it be doing that mechanistically? And the evidence, I think, so far is at least two interesting paths. One of the findings in the animal studies was that when you give those animals CBD, it can sometimes drop their body temperature. It can make them more hypothermic. And as we discussed, you need to drop your body temperature to sleep and to sleep well. So maybe that's one of the paths. The second is that CBD, and there is good science here, does seem to be what we call an anxiolytic. It's a fancy word for simply meaning it decreases your anxiety. And you can see that in these emotional brain centers, in these anxiety centers. Good brain imaging studies have demonstrated that. So, and you and I spoke about the fact that when you have this anxiety state of the brain and the body, it's going to be very difficult for you to sleep. So if you've got something that's helping decrease the anxiety, then in some ways, you're removing the brake pedal for natural sleep to occur. So rather than being a sleep generating agent itself, it's actually just removing one of the roadblocks to your ability to generate the sleep that you need. But again, we have no idea right now what is going on with CBD. Lots more work needs to be done.
Yeah, that's the future of it, as opposed to what patients want to take right now. So I think that's the important classification.
Exactly.
There. The short, quick follow-up there is for my patients that look for prescription medications to help them sleep, I really try to avoid that to the highest degree. I don't want them to build up a tolerance, a dependence. I want to find healthier ways to get them good sleep. In some cases, you do need to do it. In the cases that you do use those medications, do you find that it impacts any of the natural ways that we experience sleep? Does it change the cycle length? Does it change the restfulness of the sleep? Or is it the same quality of sleep, drug or no drug?
And it very much depends on, which of the sleep drugs that are being used, but the sort of the typical ones, and I won't name any names that people would know. You're absolutely right. And again, here's a situation where I am not a medical doctor, but I have spoken to many medical doctors, and it's very clear in medicine that there can be a time and a place when those medications are a lifeline for people when they are in really bad shape with their sleep. But we also know that medicine does not advocate for their long-term use. It's weeks, if you look at some of the recommendations, not months and certainly not years. And if you look at the average duration of sleeping pill user, it's in the years. So something's amiss in that regard.
That's why I want to hammer this point so strongly for that exact reason, because so many patients will find a physician that is willing to do that for the rest of their life. And I want them to be aware of, are they getting the same good quality sleep without with the medication versus without, and getting good sleep? And obviously I can talk about the medical aspects of the negative effect of taking those medicines.
Yeah, I think it's such a great question. We certainly know that you can build up a tolerance to them, and so you need sometimes more of the drug to get the same effect. Also, when you stop using it, you do typically get a pretty nasty insomnia rebound effect, where not only do you go back to the bad sleep that you were having, it can sometimes be even worse after a longer duration. One of the findings looking at some of these sleep medications is that if we go back to those deep electrical brain waves that I was describing, I can sort of look at the electrical signature of your sleep by using electrodes on your head. And if you dose people with those typical sleep medications, sometimes you can get, depending on the medication, a sort of a dent in the amount of deep sleep that they're getting in terms of the electrical brainwave patterns. So to your point, is it exactly the same type of sleep? you can argue from that data that from what we call an electrophysiological perspective, from the electrical quality of your sleep, it's not the same as natural sleep. It does seem to have differences. What are the consequences of those? We probably don't have enough evidence yet to understand that. And then there are also some, side effects, of course, that you're well aware of. People have, morning grogginess. They can have hangover effects. They can have impaired cognition during the day, that they don't think particularly well, or they can't think straight. And so these are things to be mindful of. And your physician, if they're a physician as good as you, will help people understand those risk versus reward sort of relationships, and then also know. There are other options, just as we spoke about cognitive behavioral therapy that can help. And often cognitive behavioral therapy for insomnia is given in conjunction with, to begin with, some of these sleep medications, just so that you really help, throw a big safety net under that patient, capture them in, start to give them reassurance, because there's nothing worse. And I've been through this with my bouts of insomnia. All of a sudden, when you lose all confidence in being able to sleep, it is miserable. And night after night, you go into the bedroom, you look at the bed, and the bedroom is just your enemy. You just don't want to be, what's coming. And all of a sudden at that point, your sleep controls you. But with cognitive behavioral therapy for insomnia and these different approaches, you can turn the tables. Now you control your sleep. You regain your confidence in the ability that you once had, that you can start to sleep better. If there's anyone who feels more like the former and not the latter, there is hope for you. Speak to your doctor. You can get better.
Yeah. That cognitive behavioral principle is so interesting for my patients, especially who believe that whether it's their mental condition of anxiety, depression, or their insomnia, that there's a chemical imbalance. We can address chemical imbalances with CBT. Like we've seen
That's right.
Therapy impact chemicals, neurotransmitters in our brains. And I'm sure that I can't speak exactly to the research, but I would expect that you would see the same in your sleep waves of an EEG pattern on a sleep study.
Absolutely. You can see it in so many different sleep metrics. That's so well documented now. One of the benefits of cognitive behavioral therapy, unlike pharmacology, is that once you start working with your therapist, and the classic approach is maybe that you see someone, for an hour, and maybe you have 6-7 sessions of that. Once you're up and running, it's sort of in terms of, you hit cruise control and you're on the freeway. At that point, you can do very well armed with all of this knowledge. And when you stop working with your therapist, those sleep benefits continue. Now, some have been documented 5 years later. Whereas if you stop using the sleeping pills, pretty straight away, you go back to your bad sleep. So I think those are some of the other advantages.
Yeah, that's awesome. There's so much overlap with mental health and sleep. That's why I'm very passionate about the subject. And obviously, Professor Walker, thank you so much for coming in, chatting about sleep.
Thank you so much, Mike.
We hope everyone checks out your book. We have it listed down below. I really enjoyed reading it. You taught me a lot, so I want to thank you for your time.
It's a privilege and a delight. Thank you so much for having me. And thanks for what you do, Mike.
Remember, having a podcast blow up is no easy feat, so I need your help. I need you to leave 5-star reviews. And when you do leave your review, don't forget to add a medical question to the body of that review, because I answer them at the end of every podcast. In fact, let's get to some right now. We have Liz Walto asked a question: is a resting heart rate of 110 beats per minute too high? Liz, we have to be very careful here, because I don't want to say what's normal for you, because I don't know your age, I don't know what medical conditions you may have, but generally speaking, you want your beats per minute to be 60 to 100. That being said, do I have a patient that's slightly above 100 that we still consider it normal for them? Yes. Do I have a patient who's in the 50s that is normal for them? Yes. But remember, there's also a huge difference with ages, because heart rates in those who are younger are higher, and that could be the total norm for them. So that's why it's important to get more information when answering questions like this. Mitch No 2525. I'm currently in college for a degree in med lab sciences at the University of Washington and planning to go on to med school and specialize in hematology. I also do undergraduate research part of the time and have begun training in martial arts after stopping for a few years. I can understand. Do you have any advice on how to navigate a busy schedule and avoid severe burnout, which has been an ever-looming threat for me and my peers? I think a lot of this is about balance and selection of what's taking up your time. Like if you're so passionate about martial arts and the work that you're doing with your education, do not cut those things out of your life. But if you have certain things that you're doing that are lower on your list of priorities, definitely you're gonna have to make some tough decisions here. For example, I used to watch the NFL or basketball a lot more often than I did after I started doing social media, boxing, all this stuff. I even used to do fantasy football. So things that I once enjoyed doing started taking a back seat in my life because of the priorities that I set for myself. So make sure that you're constantly doing a reevaluation of what is valuable to you, what is not, and constantly restructuring it, because sometimes those priorities can flip and that's totally okay. But as long as you're being insightful and checking in on yourself, that's as far as you can go when you're battling burnout, or at least preventing the battle for burnout. Mistress Blush. Medical question. Why do I sneeze when I am really hungry, usually several times in a row, instead of my stomach growling? Interesting. I have no idea, to be honest. Most people, their stomachs don't even growl when they're hungry. That is more of like some pseudoscience that we've created because it happened and people have propagated that myth. It can happen though, because some hormones do get released when you are hungry. There might be some kind of histamine-related response in relation to when you're hungry, but nothing that comes to the top of my head. Sorry, Blush. Sims123, how bad is diet soda actually? How bad? I don't like to ever say something is bad or good because that's not really a full picture of what these things are. I'll tell you why I try and avoid diet soda as much as I can in everyday life. But if I had to choose between diet soda and a regular soda, diet soda is probably a better choice if you're trying to watch your sugars, because diet soda is usually 0 sugar and a regular soda has a ton of sugar. I think I just saw like a can of cola has like 12 teaspoons of sugar in it, which is an absurd amount of sugar. So I prefer diet soda in this case because I'm cognizant of the amount of sugars present and I don't want to bomb my body with sugar, but that could be different for other people. Diet soda, the issues that come up is you start getting artificial sugar as the sweetener being in there, and that can cause some issues with the bacteria that live naturally in your gut. It can make some changes to where the bacteria that are in your gut that can get calories out of that sugar, the artificial sugar, and multiply, which means that you might start developing cravings for more sugary foods. Your taste buds will change because remember, a lot of these artificial sweeteners are at times even sweeter than regular sugar, and that changes your psychology. Do we have research that this is really bad for you? Not really. My whole thing is just go for water, sparkling water if you need a little twist, and if you have a soda every now and then, I'm not going to be the doctor that attacks you for it because there's a lot of risks in life and we need to be very thorough and careful about managing these risks. And if you have one soda once a month, that's not the risk I'm probably going to focus on with you as a patient. Alrighty, we answered some questions. Keep hitting me with those questions because I want more. Leave 5-star reviews. As always, stay happy and healthy.